Please wait. Yes, ma'am, you can start.
Yeah, start.
Sneha, unmute yourself.
A very good afternoon, all the esteemed faculties, respected ICOG Chair, Dr. Lakshmi, Dr. Ramani Devi, and Dr. Asha Rao, the conveners for the online certification course, all the esteemed faculties and all the co-conveners, all the attendees, a very warm welcome to all of you. And at the outset, let me thank Dr. Ramani Devi and Dr. Asha, along with Dr. Lakshmi, for the opportunity having us as co-conveners. And I request Dr. Ramani Devi, I request Dr. Lakshmi to say a few words about this program first, and then we listen to Dr. Ramani.
Yeah, thank you, Sneha. Thank you so much. So on behalf of ICOG, I welcome our series convener, Charmila, conveners, Ramani Devi and Dr. Asha Rao, and co-conveners. And for today, the co-convener is Dr. Sneha Bhuyar. I take this opportunity to welcome all our esteemed speakers, chairpersons, experts, moderators, panelists. Please excuse me because I'm not taking individual names because it will take a lot of time. And I also take this opportunity to welcome all those delegates who are so eager and interested in updating their knowledge about endometriosis. And Dr. Ramani and Dr. Asha have come out with a very, very useful 12-hour module to give you a lot of take-home messages about diagnosis, about management of endometriosis. So without wasting much time, I hand over back to Sneha for further proceedings.
Thank you so much, Dr. Lakshmi, for that very sweet and warm welcome. And yes, we don't want to waste time. Definitely, your vibrant activities are palpable all over the country, and we congratulate you for the ICOG activities. I invite now Dr. Ramani Devi, who is the convener of this program. And
today, Dr. Asha will be compiling the
Dr. Asha, yes.
J1.
I request Dr. Ramani Devi, who was the past vice president of FOGSI and the expert of this field. So I request Dr. Ramani just to say a few words, and then I request Dr. Asha to sum up with the one program.
Thank you, Dr. Sneha. It is indeed a great pleasure for me to have delivered some few messages on this second day of ICOG class, which has been formulated by Dr. Lakshmi Srikante under her guidance. Me and Dr. Ashara were able to do this program in a successful way. Yesterday it was very nice, and we had so many participants, and all the faculties were extremely good, and the pre and the post tests were taken. Today, I think it will be still more, I mean, we are used to tune to yesterday's program, and we will be doing it more perfectly. So I thank you and all the other co-conveners for having accepted to be the MC for this each day's program. Thank you.
So friends, today first Dr. Asha Rao will be revising what we covered yesterday in 10 minutes, which will be followed by pre-test. And this pre-test is having 30 questions, and you will be given 10 minutes to solve this MCQ. And after pre-test, we will start with our day 2 module. So Asha, please take the revision of day 1. Asha?
Yes, thank you. Thank you, Dr. Lakshmi and Dr. Ramani, for giving me this honor of summing up yesterday. Yesterday was a real Jnana Ganga, I could say, a knowledge on endometriosis. The program was compiled beautifully under Dr. Lakshmi's guidance by Dr. Ramani Devi and me. And the day started with Dr. Charmila, the series convener, welcoming the gathering. We had a very good attendance, almost 300, which was very impressive for this endometriosis certification course, because all of them have to attend the 3 days of 4 hours each, that is 12 hours module, and they had to write this pre-test and post-test, and then only they will be given the certification. And the day started with the Dr. Lakshmi giving the inaugural address and blessings, and it was an eye-opener because the magnitude of the problem was discussed, the risk factors, the predisposing factors, the genetic factors, and how the endometriosis is on the rise was beautifully discussed by Dr. Lakshmi. And prior to that, Dr. Ramani Devi addressed us, which was really an eye-opener, because we realized that almost 200 million women world over are suffering from endometriosis. And of these, nearly 40 million women are in India alone. That means there are so many suffering women here. Endometriosis brings down the quality of women's life. And there is an urgent need to spread awareness on endometriosis, not only among the women folk, but also among the doctor fraternity. Because many times we see medical students, scientists, wasting quite a few years, and there is so much delay in diagnosis because this disease, in spite of 200 years of research, yet we have so many difficulties in diagnosis and dilemmas in management. So this course has been brought on to increase awareness among all the clinicians. And following that, we had an address by Dr. Sampath Kumari, who spoke on the topic of adolescent endometriosis. The need to avoid delay in diagnosis was emphasized by Dr. Sampath Kumari. And the need to avoid repetitive laparoscopies, surgical procedures in these young girls was discussed. She beautifully told us about the medical management and how medical management needs to be given for a long time, because many people just give it for 2 to 3 months and then stop it, and then the disease recurs. So it's very important to give medication for a long term, and it has been found that it is pretty safe to give certain medication for a long term. Dr. Ramani Devi also told us that you can give it for almost 5 years and more, because there are good studies like Visado and Visan, which have emphasized about the long-term medical management. Then there was a lovely talk by Dr. Kuldeep Jain on imaging in endometriosis. Imaging in endometriosis is of great use to us because it is a non-surgical diagnosis. You can diagnose endometriosis with almost 80% accuracy, unless it is minor superficial lesions. His slides were beautiful, and he really has emphasized how to use imaging for diagnosis, avoiding, once again, invasive diagnosis. And then we had a fantastic lecture by our dear international speaker, Dr. Philip Descamps, on non-invasive diagnosis of endometriosis. It was like going in dreamland, that you can just spit into a plastic tube and your saliva can tell you whether you are suffering from endometriosis or not. It's really like a dream come true. From the days of repeated laparotomy or laparoscopy for diagnosis to come to this non-invasive diagnosis by salivary method is really fantastic. The cost, of course, today seems to be around 700 euro in Europe. But according to him, you do this at the end of empirical medical therapy. If there is no response to empirical medical therapy, before you diagnose for invasive procedure, you can do this test. And if this has a accuracy of almost 90% and above, I hope we are able to get it to India sometime with lesser cost. Then we had an excellent talk by Dr. Pratik Tambe on changing trends in medical management of endometriosis. As usual, Pratik is full of points, very right way of presenting the topic. And he told us about the various modalities, various drugs available in medical management, the safety aspects, when exactly to use medical management and when not to use medical management. It was a wonderful talk. Then we had Dr. Hepzibah Kirubamani speaking on endometriosis in perimenopausal women. It was a crisp talk. She's a wonderful teacher, I would say. She spoke about the need to differentiate endometriosis from other diseases in this perimenopausal age group, because we should not miss out on malignancy. And also there is a higher incidence of malignancy in women with endometriosis. And what type of HRT is to be used in these women with endometriosis was stressed upon by Hepzibah. And Dr. Pradeep Kumar Mitra, he's a man of few words, but he's a strong, silent worker. He spoke on how to create awareness about endometriosis for both clinicians and patients. He has done immense amount of work in Bengal, we know that. And he told us in an exhaustive way how exactly you can do it. It was really impressive. And then we had this young, brilliant speaker, Dr. Shaijush, talking on stress in endometriosis. It really touched our hearts. The way we can create problems, by repeated surgeries and the stress of the patient and how to help the patient. Because many of us today may not even talk to the patient. We are not willing to give the patient 10 minutes of our time. We will talk to our assistant saying, okay, send her for an ultrasound, let her come back with the investigations, and then we will see. No, you have to listen to the patient. You have to share her agony and give her guidance, give her a crutch. This is very important. And it was beautifully dealt with Dr. Shaijush. Then we had an excellent panel by none other than Dr. MC Patel. Panel discussion on medical legal issues in endometriosis with Dr. Parag Binawale as expert, who spoke in a crisp way about endometriosis. And we had panelists, Dr. Deepa, Shobha Gudi, Arulmoli, Gayatri, Krishna Kumari. And it was a wonderful topic which the master of the panel discussions, Dr. MC Patel, dealt beautifully. How to avoid litigations, what type of consents were to be taken. All this was discussed beautifully. And we thank our convener. First of all, let me thank Dr. Lakshmi for having given us this opportunity. And I thank Dr. Ramani Devi, who has crafted such a beautiful program. And our conveners yesterday, convener of the day was Abharani Sinha, and the chairpersons were Sneha Buyar, Abharani, and
Dr. Basap.
Dr. Basap, yes. They did excellent moderation, and the program went on till 8:30, and all of us enjoyed. I'm sure all this doctor fraternity who attended this would have been really, really benefited, and they also did the pre and post course tests. So thanks once again, Dr. Lakshmi, for having given me this opportunity.
Thank you so much, Dr. Asha. That was a very excellent compilation and, of course, a very good recap for all the attendees as well. So we welcome all of you for today's program, and welcome Dr. Charmila, the series convener as well. In spite of a busy schedule, she has joined with us. And now I think because we have some time, we can start with chair's permission. We can have the pre-test for today.
Yes, pre-test.
So,
Dear delegates,
yes.
I
Nilima, yes.
the link in the chat box. So you have to open your chat box. You click on the link and start solving the MCQs. She will be putting the timer, and the time given is 10 minutes. So Komal, please post the link in the chat box and start the timer.
Yes. I think we, yeah. Good afternoon, NM sir. Welcome.
Yeah, she has posted the link in the chat box and started the timer.
Just for the information of the delegates, attendance for all 3 days is compulsory. Google link is already posted in the chat box, and you are given 10 minutes, and you can go ahead. Welcome, sir. NM sir, a very good evening and welcome. Yes. So we have you in time. Sir has reached in time.
Hello, good evening, everyone. Yes, I'm right here. Okay. Okay. So what's happening now? When do I start? When are you?
हाँ हाँ नहीं आजा आजा चलते अपन आजा मैडम नहीं है यूसी को फोन कर रही है तू कर रही
Sir, the pre-test is going on and we have to wait for total 10 minutes.
Okay, okay.
Another
Great.
6 more minutes to go.
Yeah, four.
Okay,
6
perfect, perfect. I'm right here.
yeah 6 minutes more and then you can start yeah
I think the time is up. Nilima.
Yes, ma'am. Yes, ma'am.
So can we start with the session? Yes, a very good afternoon. I, Dr. Sneha Buyar, today's convener for this program, welcome you all for this first academic session. And for this session of classification of endometriosis and Mullerian anomalies in endometriosis, fertility preserving surgery in endometriosis and DIE, I welcome the chairpersons, Dr. Sudha Tandon and Dr. Kundavi Shankar. As you all know, Dr. Sudha Tandon, she's a senior gynecologist from Mumbai, and she's the senior most gynec endoscopic surgeon who has actually started first endoscopy in Chembur. She was a chairperson for Sexual Medicine Committee, FOGSI, and she's the treasurer of IIJ at present. Welcome, Dr. Sudha Tandon, for this session. Welcome, madam. You can unmute yourself. Welcome, Dr. Kundavi Shankar, who is a National Board Certified obstetrician gynecologist in the field of reproductive medicine and endoscopy. She is also trained in ultrasound and andrology, and she's got lots of publications to her credit. With this, I hand over the forum to you both. You can continue with the session. Over to you, Dr. Sudha and Dr. Kundavi.
Thank you, Sneha, for your kind words. And we welcome all the speakers, all the ICOG board members and the delegates for this session. So can we have the CV of the first speaker, please?
Lima, can we have this CV? I'll share otherwise. Yes, can you see? Sudha ma'am, can you see?
No, it's not seen.
Right?
Yeah.
Ma'am, please make it
Yes.
slideshow.
Yeah, make it slideshow, you play the button.
Yes, that I'm doing.
Yes, ma'am. Now visible.
Yeah,
Yes, ma'am.
yes.
Yeah.
Can you
So
see the screen?
yes. Of course, though the font is still small, but I have the pleasure of introducing a very giant of a person, Dr. Narendra Malhotra. Who doesn't know him? He's a very well-known personality from Agra and from India and all over the world. And he's the managing director of the Global Rainbow Healthcare, director ART Rainbow, director Manyata, and director Project Positive Health Rotary District, International Relations, Director Ian Donald School of Ultrasound, Professor, President INSUG. He has been the past Vice President of CEFOG and BAPM, immediate past President of Rotary Club of Agra, past President ISAR, ISPAT.
enough, okay.
Chalo, please, we are all eager to listen to Dr. Narendra Malhotra, a very towering personality and very warm person also. I know him personally. And so let's go on to the first topic, Dr. Narendra. We're all eager to listen to you. He's going to talk on endometrial evaluation by IDEA, International Deep Endometriosis Analysis Group. Yes.
So thank you very much. Greetings from Agra. Actually, I think I've been put as a staff speaker in place of Niharika, but she's not, she's busy today. I have no disclosures or conflict of interest. And my workplace is in Agra, right? Case scenario. It affects almost 15 women, 1 in 15, reproductive age group, cause not known, not clear how it can be prevented, not known how to predict this disease development. No simple test except surgery, and even on operation, sometimes it's an educated guess. And there are at least 4 treatment options, none better the other. Welcome to the world of endometriosis. Endometriosis world over today is about 15 to 20%. Even in India, we thought it was more in South India, but it become equal at 25. And here is a painting of endometriosis awareness through an art association, which shows how challenging and elusive and painful this disease is. So 20% Asian women, 5 to 20% remain asymptomatic, and 50% of infertile patients have endometriosis. Even in adolescent pain, pelvic pain, 25% of them will have endometriosis, and it is even seen in perimenopause. So dysmenorrhea, dyspareunia, and infertility. So what we should be doing? Have we done it right, or should we go and turn a new leaf on endometriosis, find new solutions, medical management for pelvic pain, infertility, and pelvic masses? Now we have the ASHRAE guideline telling us, and the ASRM guideline telling us, and the Cochrane review telling us how this disease should be managed. Before I come to actually classification and idea for endometriosis, let's see the adolescent, adult, and postmenopausal group. In adolescent, the endometriosis will be at the peritoneum and ovarian surface and will cause angiogenesis and endometrioma, so adhesions. In adult, it will be in the peritoneum, so adhesions, typical adhesions, ovary, endometrioma, and DIE at the rectovaginal. While in postmenopausal, it is mainly in the ovaries and sometimes in the extra pelvis, so cause obstructive lesions. So endometriosis is detected in about 30% of infertile women. Adhesions are common, and smooth or shaggy walls may contain solid areas inside and ecogenesis. The classic, what we used to say, is ground glass appearance, but it may mimic anything. It may be septated like this, classic ground glass with a small nodule, or even reticular pattern with ecogenic flex and a lace-like pattern, as you see in hemorrhagic cysts. That also could be endometriosis. When we put the color Doppler on, there is no color inside. It's all on the periphery, even with the 3D. So came the various classifications. So we had the mild, moderate, and severe, and then we had the infertility Adamson's classification for predicting fertility, and then we have the Ensign score. The Ensign score divides the pelvis into anterior and posterior compartment, and the cul-de-sac in the vagina, you have E1A, E1B. Now, it's quite theoretical, this scoring. So we can read it in any journal, or you can take a picture of this, click it, and then go through and then make a scoring. So it goes from E1A to E3C, where the infiltration is of the rectum, but without stenosis. So that was the Ensign score, which was being followed by a lot of us to score the severity of the disease. And it goes to E4, and finally FA, where it goes into the adenomyosis or in the uterus. Then we have FA, FB, and FU scores. So that is how it was scored at. And when you do a laparoscopy, you will be scoring this. But the simplest way to score endometriosis was the RAFS scoring, or the revised American Fertility Association scoring system, where we said mild disease, where the score was 1 to 5, and 2, where the score was 6 to 15, and 3, where the score was 16 to 30, according to RFS, and stage 4 extreme. And this predicted fertility and predicted what type of treatment we should be doing, and taking them straight away for IVF or doing a laparoscopy. So this is the revised RAFS score, and minimal lesion, mild lesion, moderate and severe lesion, and then you revise it and put it in the scoring sheet, and you get the score, and depending on what score you put them on, mild, moderate, and severe. So how should we go about this disease? Well, symptoms, clinical, sonography, radiology, ultrasound, MRI if required. The catch situation is the history can be misleading and not much information. Staging involves extensive investigations, and finally laparoscopy is the gold standard for this. So the questions we need to answer is staging necessary before surgery? And how do we associate extrapelvic endometriosis in account in the staging? And inclusion of malignancies and endomyosis. And let's be very optimistic, from the scorings which we just saw, NZL score and all, we need to have a better, simpler, accurate staging and documentation. So came the idea. Now, idea was a systemic approach to sonographic evaluation of the pelvis in women suspected with endometriosis, including terms, definition, measurement. And this group was formed, called as the International Deep Endometriosis Analysis Group, or IDEA, and they have a 15-page document which was published in 2016 and again revised, and then you can go through, and these are the people who are involved in it. So we have the idea scoring, but before that, endometriomas, we should know how they are caused. And I acknowledge the help of Michael Bajak, who was responsible for this publication and responsible for this red Indian sign. Now, this red Indian sign, if you see a sign like this, between the ureter and the rectum on the posterior, it is a DIE. So this was a classic sign which he described and which makes things very easy on. So idea is a statement of consensus opinion, and it standardizes the terminology, and all of us should be talking the same terminology. So let's see what idea says, or idea tells us. So with the idea, we are going to talk about peritoneal disease. We're going to talk about EMOS and IMOS. AMOS. EMOS is endometriomas, and IMOS is the adenomyomas. So with EMOS, endometriosis, you will have peritoneal disease. You'll have adhesions, you'll have endometriomas, and you have DIE. And 5 to 10% of all endometriosis are going to be EMOS or endometriosis. The EMOS affects even up to 45, and the typical lesions are in the anterior compartment, 10% and 90% in the posterior compartment. So DE is very important. And this is how we divide the anterior compartment. Anterior compartment means anterior to the uterus, and the lesion here, and the lesion here, and the lesion. So 10% lesions in the anterior compartment line, and 90% of the lesions are in the posterior compartment or the rectovaginal. So this is a diagrammatic schematic drawing of DI locations and transformation of EMOS. So what we need to do is we need to do a pelvic examination first, and that includes a per speculum, because you might have a nodule on the cervix also, and that gets a score. So speculum examination, vaginal palpation, nodule detection by palpation is more sensitive, because once you're sliding your finger and you'll feel the nodule and patient will feel pain. So this will explain us the underlying symptoms and map the disease and assess the severity of the disease. So palpation, very hard nodules, sensitive tightness, adenomyosis or EMOS. You'll see hyperechoic areas in the uterus, which we'll just come to. And endometriosis or EMOS, you'll see the hypoechoic areas. So look for direct signs and look for indirect signs. Direct signs are tumor, that is endometriomas, or nodules bigger than 5 by ultrasound or by laparoscopy. As you can see here, the blue nodules. And look by adhesions. By ultrasound, we do the push and pull sign and Timotrish sign, and so based on this, you can put them as classical, soft markers, POD markers, and nodular markers. So step 1 is the ultrasound, where you see the posterior anterior compartment. Step 2 is define between endometrioma and adenomyosis. So classical adenomyosis makes it AMOS, and classical endometriomas make it EMOS. So adenomyosis is AMOS, and we'll just come to what we see in AMOS. Now with EMOS, the mobility is reduced, and we use to classify the myometrium in the uterus. We use the MUSA this thing. And MUSA is the morphological uterus sonographic assessment consensus opinion, where we see for the radiations, we see for irregular thickness, we see for breakage in the endometrial cavity, we see for salt and pepper appearance, we see for lakes, we see for striae, and this is how it appears actually, diagrammatic and actual appearance, and we see for the rainforest sign. So these are AMOS morphological signs by ultrasound. So in AMOS, the first is that you know or identify all the signs which are there. So there could be lakes, there could be hyperechoic, there could be salt pepper, irregular thickness, breakage of the myometrial and endometrial junction, buds, islands, lines, all these you need to study, and then you will tell them. So here is a picture which is showing everything. It's showing buds, it's showing lines, it's showing islands, and it's showing the salt and pepper, and it is showing unequal thickness. So complete, and this type of picture will tell us this is endometriosis of the uterus. You can put color on, and you'll see that the colors of spiral artery flow will go into these areas, because these are endometrium, and they'll respond to the hormone estrogen and progesterone. Then some type of AMOS is projecting into the endometrial cavity. And here, while doing a hysteroscopy, I found a bulge, which was bluish. I thought it was a submucous small myoma. So let me just resect it out. When I resected it out, it was a full lake jutting into it. So it was endometriosis. Amos, and that's how the myometrial cyst appeared in the ultrasound when we look back. So this is what you can run into it. For extra uterine, ground glass typical appearance, kissing ovary sign, adhesions, movement sign, and then sometimes they may also have pregnancy along with it. And in pregnancy, sometimes this lesion will be. So now to locate the lesion, we go for IOTA scoring. IOTA is International Ovarian Tumor Analysis Group. So to classify unclassified, this is not a classical ground glass. So it could be liquid or it could be solid. So when we push, we get the swashing sign. And if it's a swashing sign with a picture like this, then it makes it. This is a typical endometrioma. This is an atypical endometrioma because it has a nodule. And if this nodule is big, then in the IOTA scoring, it comes to benign 4 or it comes to maybe malignant M1. And you need to know that. So typical endometrioma will be uniocular ground glass. Atypical could be not ground glass, fluid levels, that is swashing sign, multilocular, retracted blood clots, papillary projections, small ones, calcification, completely atypical. And this is how it could present. And even all these by IDEA scoring comes into step 1, diagnosis of EMOS or endometriosis. See, the lesions are less, the projections. If the solid areas are more, it goes into IOTA M scoring. And that makes it into malignant, suspicious malignancy. So ground glass is one. This is simple ground glass, very good. You see acoustic streaming and you see acoustic enhancement. And this is no acoustic streaming. So you start thinking this is a hemorrhagic cyst or a solid cyst. And acoustic streaming will be there. See, when I push this, tried to push this ovary, first we saw some clear fluid and then came the chocolate. So that clear fluid formed a level by the ultrasound. And this causes acoustic streaming. But it cannot differentiate reliably between endometrioma and other type of tumors unless you see. So if there is a mixed old blood, you might have fluid levels, old and new blood, or you might have a slowly growing endometrioma. And you might have layering, old and new, and you might have the clear fluid level, which could be there, which is known as liquid streaming. And then comes the thick one, and that has no streaming. So again, we are trying to show you that when we push the ovaries and the endometrioma opens behind it, and the classic sign is, of course, the kissing ovary sign with omentum. And when you put a scope in, we see that with the omentum tag in it, and we go ahead and separate them and treat them laparoscopy. The step 2 in EMOS is the soft markers. Soft markers is tenderness, ovary is thick, you see a flapping sail sign, and even the tubes get filled, and you see a sacrosalpinx. So ovarian mobility adhesion is very easy, push and pull sign. This is how we do it. I'm pushing and pulling. If the ovary and uterus slide over each other, there is no adhesion. If they slide together, it's an adhesion. So judging the ovarian, this is stuck to the ovary. This is stuck to the ovary. Ovary is stuck to the uterus and the. So both ovaries are stuck to the pouch, and the sliding signs is negative. Sacrosalpinx is there. The fluid is collected into the tubes also because of inflammation, and you get a sacrosalpinx. This was very interesting. Yes, we did a hysterectomy and left the ovary back, and when we left a few months back, she came up with this kind of. So this could also be endometrioma. Now you don't need to operate this again. So what I do is I take this escarole, and which is used by surgeons lightly, and I take a foam of it and then drain the endometrioma, that resident ovarian cyst which has been caused, and then we will inject this escarole. So it's very simple. It is a residual cyst which has occurred. So we just catch the cyst, put a needle in, which all of us can do, drain it out, and inject, make a foam of the escarole and inject 2 ampules in the each cystic lesion. So that you can do that too. That's how was the treatment. Then the POD sign, POD is fixed. Adhesion signs, by doing pushing from above, uterus may be retroflexed and fixed, that you can make out. And when you put the scope in, you see the sliding sign was not there and there were so many adhesions. And the sliding sign was present and only surface endometriosis was there. So pouch of Douglas could be completely obliterated or completely. Then we look at the white line sign behind. So the next thing which we look at is what we call as the white sliding line sign, which is the uterine serosa, which is just getting adherent. And if this white line has disappeared, you see here, it is not, in the previous picture, it was right till here. And that's where the peritoneum reflection is. If the serosa is adherent, this white line sign. So here, see, it's all disappeared. So this will tell us that this uterus has got adherent and interrupted white line sign is there. Interrupted white line sign with uterine, interrupted white line sign. When we did a laparoscopy, you see that that is what we found. Then, of course, the nodules. Nodules could be in the bladder, could be in the anterior compartment. I think I don't have time. So it could be in the bladder, which is easy to see. It could be in the rectopelvis, which is a little more difficult, and it could be in the ureters also. So you need to know how to study the ureter. So how to study the ureter by ultrasound. That's the iliac, and that is the ureter crossing over it, and you could see nodules over it. So these are the nodules, and if the nodules are blocking, the ureter will be distended, and hydronephrosis, uretrocele, by calculus, if it is there, why it is causing, or whether it is EMOS which is causing it. So ureters could be involved in 1 or 2%, and you search for vascularization of these signs and you look at the ureters. And you can put the color on the bladder and you see the jet sign of the ureter. And all this can be accessed by all of you. These video assessments on the ICOG website, we'll go to the ICOGs, how to examine the ureters and all could be seen. So how to examine the ureter, it's a detail, and we could teach you all that, and the videos on the ICOG site teach you what to do and how to do it. There is a learning curve, but it can be done. The posterior compartment nodules, classical red Indian hat sign, and you see that, then you know it is DIE. And for that, maybe sometimes you need a MRI, but not always. Today, ultrasound by IDI experts have defined all these signs so that we have made. There are still some questions to be answered. TVS finding, which would need preoperative clarification. Do you do a cystoscopy and all? A MRI. TVS could primarily lead to inclusion of other diseases into endometriosis, which are in the peritoneal inclusion cyst and all. TVS findings could primarily lead to other treatment, also urological and all. And these questions need to be answered. I leave you with these questions, which are still to be answered, and maybe we'll be better off. And these are some of our books which we have written, 59 of them. The clinical series on endometriosis, which has just been released at AICOG, covers all this. So thank you very much, ladies and gentlemen. Endometriosis is an enigma. It is a benign cancer. You need to think endometriosis and you look for endometriosis. And if you follow the IDEA scoring and the IDEA classification by ultrasound, you will be much, much happier and much easier to pick up the small nodules and actually look for them. Thank you very much.
Thank you, Dr. Narendra. I think in a short span of time, you have covered a lot and really laid emphasis on very important points. So do we take questions now or later?
I think, can you take them now, because I have to go for surgery?
Okay.
I think for sir, we can take it, right?
Or I'll come back
The rest
afterward.
too late.
So are there any questions on the chat box?
Right now, there are no questions. It's only appreciation.
Okay.
Thank you.
Yeah. So Dr.
Thank you.
Narendra,
So I'll join in. I'm joined in 1 hour. If they're there, after 1 hour I can take. I'll just do one case and come.
Okay, sir. Thank you, sir.
all right. Okay. Just a quick one, Dr. Narendra. I mean,
Yeah.
The way I looked at it, you are very more for sonography, but there are a lot of workers and who have worked on endometriosis who talk primarily of MRI. So between the two, I think, what is it that, which patients on sonography, you will definitely do an MRI? is what.
So the first thing is MRI is not available everywhere. Ultrasound transvaginal is available with everyone in tier 2 cities also, where the commonest of gynecologists, general practitioners, all have TVS, all have color Doppler. And the signs are not difficult. Now, there are some lesions which are indiscriminate. That's why in my last slide said TVS, you might still, there are some lesions of the adjacent which might confuse you, which are urological or gastro lesions. And if you are in doubt, definitely we will go for MRI. But classical endometriomas, bilateral kissing ovaries, sliding sign, DIE nodule, anterior compartment nodules, these are to be done only by ultrasound. Where you are in confusion, it's a solid lesion, it's extending, you have to check out the lymph nodes, what are there, maybe their MRI. So I think about 10% of my ultrasound would need to be, maybe less, even less than 10%, I would go for an MRI.
Right.
I would rather go for a laparoscopy and diagnose and treat at the same time.
Right. But I think for a bowel lesion, probably an MRI to know how much it is invading or how far.
So you are prepared for surgery.
Yes, and then you're prepared for surgery, because then you would really want to involve a GI surgeon to decide on the type of surgery you would like to do, whether it is shaving or end-to-end anastomosis or, just a discoid excision. So I think those cases where there is a posterior compartment, probably an MRI would be more of benefit.
Agreed. That way cystoscopy also. That's why I kept TVS may need cystoscopy, MRI, contrast and things like that for
difficult
cases. One question in the chat box. What is the sclerosing agent you are going to use to reduce the
Ascarol. It's a plano alcohol derivative. It is marketed as Ascarol. It is only 100 rupees an ampule. It is very widely used by surgeons to put in varicose veins and piles. So it is simply available everywhere. And it is a sterile. It can be used intravascular also. It doesn't cause all that problem. So it is used in varicose veins. So it's and if it leaks also in the peritoneum, it's not going to cause. So while if you put pure alcohol, sometimes that causes irritation. This is sterile and antiseptic.
Developing an abscess by the sclerosing agent?
No, I have not seen. We are using. See, previously we used to use tetracycline in oil. Now tetracycline in oil is not available for human being. It is still available, the animal tetracycline. We use that also in some cases. That works terrific, and it's an antibiotic. Then we started using pure alcohol, medical alcohol, but that causes irritation. And see, anything going into the peritoneum, a needle, it can through the transvaginal route can carry infection potentially. So you have to take care of that. Potentially, yes, it can cause all those, but then you save a lot of people from major surgery.
You use these agents in a recurrent endometrioma.
We use it in simple cyst, pre-IVF, simple cyst where it is not vanishing and you have to start stimulation, take it out. 20% of them will get cured. So 20% laparoscopies are saved for cyst 5 centimeters pre-IVF, which are not vanishing only. We also use it in hydrosalpines.
Okay. Sir, have you got any experience with GNR agonist that's being injected into the endometrioma?
Local. No? I heard this. I'm going to try it. I have not yet tried it.
Evidences for that, literature evidences for that.
I know.
I think currently the ESHRE guidelines also, they are supporting aspiration and then this sclerosing agent injection. Yeah.
Thank you, sir, for the wonderful talk on, I think you took us through the idea, like how to go about the ultrasound. I'm sure that everybody would have enjoyed your talk. And let's move on to the second one. We have Dr. Priyanka Roy, who's going to talk about Mullerian anomalies and endometriosis. Can we have a CV, ma'am?
I have the video of them. So should I share directly the video?
Yes,
madam.
Recording of 15 minutes.
Yes, you need to share.
Should I share it? Okay, ma'am.
Yes.
Good evening, everyone. I'm Dr. Priyanku Roy.
Ma'am, please tell me, is it audible?
Yes, yes. Very
Okay,
well
ma'am.
audible. Yeah.
Okay, ma'am.
And I would like to thank all of you for giving me this opportunity to be part of this endometriosis certification course. I especially like to thank Dr. Ramani Devi ma'am and Dr. Asha Rao ma'am for giving me this opportunity. Going ahead with the topic that has been given to me, Mullerian anomalies and endometriosis, an enigma indeed, not very well understood before, but now with evidences, it's very well understood that Mullerian anomalies and endometriosis are associated. Endometriosis is, of course, the presence of endometrial glands and stroma outside the endometrial cavity. It's an estrogen-dependent and progesterone-resistant chronic inflammatory condition. And, of course, there are varied hypotheses for the origin of endometriosis, which probably we started learning during our MBBS days, continued learning during our postgraduate days, and are still learning because there are new theories or new hypotheses that are coming in every time. Endometriosis is associated with Mullerian anomalies. The incidence is more when there is an outlet obstruction with a significant p-value as published in 2004 by Guedes and Cow et al. In non-obstructive Mullerian anomalies also, endometriosis exists, but with lower incidence and severity as compared to women with obstructive Mullerian anomalies. So basically, what we come to infer is the fact that Mullerian anomalies and endometriosis are correlated. It will be in cases of outlet obstruction or in cases of non-obstructive non-obstructive Mullerian anomalies as well. So we look at the incidence. Sorry for it. It dates back to the 16th century in a case of a uterovaginal agenesis that was published in 1600 by Colombo et al. In a general population, it is 0.1 to 3.5%, but in cases in recurrent abortion in the second trimester, 15 to 25% is approximately the incidence. Septate and arcate uteri accounts for 75% of Mullerian anomalies, as was published in 1997. And in a clinical practice also, or in a day-to-day practice, when we do hysterolaparoscopies, we definitely see more cases of septate and arcate uterus that are the common forms of the Mullerian anomalies. Jeremy et al. Published a very interesting article of endometriosis and uterine malformations, and they said that the overall prevalence of endometriosis in uterine malformation cohort was 50%. However, moderate and severe endometriosis was more frequent in infertile than fertile women, and there was no difference which was found regarding the class of the malformation. We look at the prevalence of endometriosis as per the ACOG 2000. Chronic pelvic pain constituted the most common symptom in association, of course, especially in cases of adolescents, where chronic pelvic pain was the main complaint in approximately 50% of cases, followed by subfertile women, and also, as we know, 2% of women could be asymptomatic as well. Now, Asian et al. In 1992 said, Mullerian anomalies and endometriosis are commonly seen in second and third decades of life. Genital malformations is present in 4% of all patients with endometriosis. Of patients with malformations, 11.2% had endometriosis independent of the kind of uterine anomalies. Most studies quote the incidence being 5 to 11%. 72% of girls with Mullerian anomalies with outflow obstruction have endometriosis in comparison to 10 to 15% in non-obstructive anomalies. There is regression of disease once surgical correction of the obstructive anomaly is done. So that goes on to suggest more that Mullerian anomalies and endometriosis are associated, and in the presence of Mullerian anomalies, the incidence of endometriosis is even higher. The classification goes back to 1979, the one which we have commonly read in our textbooks and we still remember, Buttram and Gibson's classification, which was further modified in 1988 by the American Fertility Society classification. This is the Buttram and Gibbons classification, the class 1, 2, 3, 4, and 5, with the 5 being the septate uterus, the partial and the complete ones. And this was a classification that we have gone through we were learning through our OBGYN career. AFS classification of Mullerian anomalies also do exist, and here we have 1, 2, 3, 4, 5, 6, and 7. 1 being the segmental Mullerian hypoplasia or agenesis, 2 being the uniconvert uterus, the various forms of it, 3 uterine didelphus, 4 biconvert uterus, 5 septate uterus, 6 arcuate, and 7 the most dreaded diethyl steel-based stroke, that is the DES related, which thankfully we do not see very often in today's day-to-day practice. So if you look at the incidence, arcuate uterus and septate uterus constitute the major bulk, in addition to probably uniconvert uterus as well, approximately 33% each. Biconvert uterus is approximately another 20%. We have a new ESHRE and the ESG classification of Mullerian anomalies that is classified as U, C, and V. And as you can see over here, U, which is the various forms, the types of the the normal uterus, dysmorphic uterus, septate uterus, etc. The subclass, which can be T-shaped, infantilis, oral, others in case of dysmorphic uterus. And also if you look at the cervical or vaginal anomalies or coexistent class, that is the C and the V as well, that you can see in this ESG classification. Now, what are the main types of Mullerian anomalies? It could be uterine, cervical, vaginal anomalies are associated with endometriosis, and it is more seen in case of cervical stenosis, as was published in 2016. The most common etiology, probable cause, could be intrauterine infections, genetic aberrations, and teratogens like DES or thalidomide. It is often associated with renal anomalies, axial skeletal anomalies, and rarely cardiac as well as auditory anomalies. Genetics, of course, is associated or correlated with most of the diseases or anomalies in today's day. Even same with the Mullerian anomalies, which could be sporadic, familial, multifactorial, autosomal dominant or recessive, X-linked, or could be a variant of GALT. There are various theories of pathogenesis of endometriosis, which starts from the Sampson's theory. Then we have the metaplasia theory, hormones, oxidative stress, immune system or dysfunction, genetics, as well as the stem cells, which are all the theories that gets associated. And every year, if you see, or I would say every new textbook that comes out comes with a new theory that has been slated towards endometriosis. So the theories, as we have said, the coelomic metaplasia, the genomic factors that play a role. There are theories which suggest the adolescent form of endometriosis and could provide another explanation for its association with uterine anomalies. So that is mainly the coelomic metaplasia and the genomic factors. Intrapelvic injection of menstrual endometrium causes endometriosis in baboons. This was studied, and this said that endometriosis has been observed as early as 3 months after ligation that has happened, that is supracervical ligation, which can cause obstructed uterine outflow, resulting in decreased antegrade menstruation and increased retrograde menstruation. So what are the common symptoms? Retention of urine, cyclical lower abdominal pain, progressive dysmenorrhea, and continuous lower abdominal pain. And when I talk of the symptoms, I urge all of us, the juniors especially, all of us rather, I would say, that my father keeps saying one thing very interesting, that in today's generation, our younger generation probably considers the right hand to be a laparoscope and the left hand to be an ultrasound probe. But we should never forget our history-taking skills and the two important fingers that we have as well, because a good per speculum and per vaginal examination is quite very important in giving us a proper diagnosis. So diagnosis, commonest HSG, ultrasonography, which could be 3D imaging, MRI, as well as a hysterolaparoscopy. You have the HSG images over here, which shows the various Mullerian anomalies. USG, 2D versus 3D, and 3D is quite very important, quite very efficient in diagnosing. And actually speaking, endometriosis, Mullerian anomalies, whatever you talk of in today's day, hysterolaparoscopy is not the primary goal, primary modality, because we have got very good ultrasound machines, very good 3D ultrasound machines, and in case with 3D ultrasound we are not able to diagnose, we can probably subject the patient to an MRI, and that gives us very good results as well. And you see how well the 3D ultrasound delineates this Mullerian anomalies for us. MRI again showing the important pictures. Hysterolaparoscopy is the gold standard in diagnosis, treatment of endometriosis, and correction of anomalies, but as talked up by Shafron in 2021, he said a very important statement: do not put in a scope in a case of chronic pelvic pain just to diagnose endometriosis. Rather, diagnose endometriosis by other modalities like 3D ultrasound, 2D ultrasound, a very good transvaginal ultrasound, or even MRI scan if required, but do not put in a scope just to diagnose it. Here you can see a beautiful image of a laparoscopic image of a uterine groove that has been seen in case of a Mullerian anomaly. Endometriosis in MRKH syndrome, you can see the endometriotic nodules that are present in this patient of MRKH syndrome. So endometriosis in a patient of MRKH syndrome and complete uterine agenesis, the evidence suggests the support of theory of coelomic metaplasia. So endometriosis in a patient with MRKH, because a patient did not have any functional endometrium, her endometrioma is assumed to have arisen from coelomic metaplasia. There are other studies which report a higher rate of endometriosis among uniconvate uterus or among biconvate or didelphic uterus as well in association with renal agenesis. These are a few pictures which thankfully I got from Dr. Ramani Devi ma'am, and I would just like to put it up here. Uniconvate uterus with a rudimentary horn, you see the endometriotic nodules that you can see as well. This is a picture of a biconvate uterus and endometriosis. You can see the nodules in this case of a biconvate uterus. This is a uterine didelphus and endometriosis that is noted. So separate uterus and endometriosis is also an entity which could be because of dysperistalsis, which was suggested to the mechanical cause of endometriosis rather than retrograde menstruation. Septal resection does not benefit or prevent endometriosis, but chances of abortion definitely decrease, especially in cases of RPL. So this is a video, this is a photo you can see of endometriosis in a case of separate uterus, and here you can see correction of separate uterus that was done hysteroscopically. So results suggest a higher incidence of endometriosis in patients with separate uterus. As we had seen in the beginning, by 33%, separate uterus in infertile patients should be followed by a combined hysteroscopy and laparoscopy that could help in correction as well as continuation of treatment. Hurlin-Werner-Winderlich syndrome is a rare abnormality with a unilateral obstruction of the uterine didelphus at the level of the cervix or vagina. It is because of ipsilateral, it also has ipsilateral renal agenesis and is associated with endometriosis. This is an MRI image showing the hematometra that you can see. Robert uterus is another very rare Mullerian anomaly, which is because of asymmetric obstruction, obstructed lateral fusion defect. It was first reported in 1970, and it has been included in the SJ or the ESG classification as well. Here you can see the MRI image of a Robert uterus with the atypical septum that is noted. This was a study which was published long ago by David et al. In Mullerian abnormality, 64 women who were studied, outflow obstruction was seen in 13, no obstruction in 43, and no endometrium in 8 women. Out of the 13, 77% had endometriosis. Out of the 43, no obstruction, 23 had endometriosis, and in patients with no endometrium, there was no endometriosis at all that occurred. This was a similar study that was done by Dr. Ramani Devi as well, and she also stated that she had similar results. So to conclude my talk, I would say etiology fits with Sampson theory or coelomic metaplasia theory. Dysperistalsis and architectural distortion leads to endometriosis. Diagnosis is essential to prevent morbidity. Early intervention reverses endometriosis and reduces dysmenorrhea. Association of uterine malformations and infertility increases the risk of severe endometriosis. Therefore, the diagnosis of endometriosis should be considered in the etiology of infertile women with uterine malformations. And I would like to end by saying one important thing. Do your scans yourself. That gives you a good rapport with the patient, and also you diagnose things you need to see, because your mind knows what you have to see in those patients, and usually when you do the scans, you do not miss out on anomalies, and that gives you a clearer picture, a better picture, and gives you a better diagnosis of the whole situation, and you can treat the patient better. So I'd really like to thank you all once again for giving me this opportunity, and thank you for the patient hearing. I hope this talk will benefit you in your clinical practice as well. Thank you so much once again.
Ma'am, video is done, ma'am. Completed video.
Yes, I request the chairpersons to make some comments.
Is Dr. Priyankur, has he joined or is not joined?
No, he is not there.
No,
He is not there. Yeah, yes. So,
you
Dr.
can
Ramani
make
Devi,
few
would you like
comments
to
and we can move on, madam.
Yes, Dr. Ramani Devi, you would like to comment because you've seen a lot of patients and done a lot of work.
Yeah, see, whenever there is a Mullerian anomaly, and the commonest one is septate uterus, you think about endometriosis, okay? Because literature evidence, though the general incidence of endometriosis in a general population is around 10%, it is definitely increased in septate uterus. But in patients with obstructive Mullerian anomalies, it is very high, and we do get, it's not uncommon to see Herlin-Werner-Wunderlich syndrome. Though we say it is rare, what the mind knows only the eye sees. So I think with each and every Mullerian anomaly, we have to rule out associated endometriosis also. And most often, when you correct the Mullerian anomalies, the endometriosis regresses. So I have, like say, a group of 4 or 5 patients with Herlin-Werner-Wunderlich syndrome who has been successfully treated, and the presenting feature is a young girl. The youngest of my patient was an 11-year-old girl with a HWW syndrome. She was completely all right once when I did a hemihysterectomy, and now I'm happy to say that she is a mother of 2 kids. Okay.
What's the instance of the renal anomalies you've seen, ma'am, with the endometriosis?
Yeah, it is quite common. In fact, I will say one of my patients, IVF patients, she had an ultrasound for the baby, and the baby was found to have renal agenesis. I insisted my sonologist to look into the genital organs, and interestingly, that child had in utero, we picked up biconveate uterus with a hydrocolpus. So I had warned the mother that she is likely to be a case of HWW syndrome. So only we have to look at the pointers. And renal agenesis is 1/3, the literature evidence says it's common. And as well as sometimes spinal anomalies, 5 to 10% of them can have spina bifida also.
Yeah. Dr. Ramani Devi, in patients of MRKH syndrome, how do you decide whether they need, of course, vaginoplasty if they are not, the vagina is not developed, but from the angle of doing an egg pickup, how often do you think a vaginoplasty needs to be done for transvaginal egg pickup? Or I would say, how often you've done a transabdominal?
No, I don't have I don't have any experience. I had done only one egg pickup for a patient who had underwent hysterectomy for leiomyosarcoma.
Okay.
But that was comfortable because she had a vagina. Probably, theoretically speaking, we have to reconstruct the vagina. Then we have to go for pickup, or maybe a transabdominal oocyte pickup may be of use in those situations.
Right. No, we had a patient of absent uterus, MRKH syndrome. And when we did a vaginoplasty, after that, with the depth of the vagina that we got, a transvaginal pickup really became very easy. And then, we transferred it in the surrogate, and finally she's got a child of her own. But they also have a low ovarian reserve. So that is a problem with these patients, that we don't get good number of eggs.
True.
That is an associated problem.
Yeah, that's lovely discussion, Dr. Sudha. I take this opportunity to welcome Dr. Alka Kriplani, who is already there. And I think we have Dr. Mahapatra before.
No, Das Mahapatra is held up. So we'll be having Alka Madam's talk next.
Oh, that's great.
Yeah.
Dr. Alka Madam, welcome. And
unmute.
Sorry.
Unmute, madam. Unmute.
Unmute.
Alka madam, unmute.
I think madam's.
No, you have not unmuted.
Madam, please unmute yourself.
No.
The host is not.
Oh, now she's now it's okay.
I'm done, ma'am. I had made her co-host.
Madam, please.
Yeah. Welcome, Dr. Alka Kriplani. I wanted to ask you, but you were on the phone.
Welcome, madam.
Sorry,
Internet.
the HOD of PSI hospital was on phone for her sister's
So
welcome, Alka ji.
I was just waiting for you to complete your phone. And you are such an expert and, an authority on Mullerian anomalies. Would you like to,
Don't talk these things in front of Ramini. For me, Ramini is authority in endometriosis. And Asha, I'm so impressed with your, perseverance and the way you are working. I salute you. So many phone calls with so much of loving and this thing invitation. And you people have made such an excellent program. I really appreciate. So without wasting time, I
Thank you, Alkaji. It's nice to hear from you.
screen share and share.
And can we have Madam CV?
And अरे CV का क्या जरूरत है? And where has it gone? My God. New share. ये बार enter your mail और ये सब क्या करता है?
Asha ma'am, can we have Madam CV?
My slides are there.
Yes.
Yes, madam.
So it's
We can
moving.
see it. Yeah. Now it's full screen, madam.
There is no need to show my biodata. I'm Alka Kiplani, and I am also interested in endometriosis. And my loving regards and love to Ramini, whom I really adore so much, and Asha Rao, who's working so hard, and all endometriosis experts. So I'm going to learn from you people. I was listening these 2 lectures. I enjoyed. And as the topic given to me was deep endometriosis, which is really so close to heart, and so many patients, they come. And what is deep endometriosis? Anything subperitoneal, 5 millimeter or more deeper is deep endometriosis. It can be bowel, bladder, ureter, rectovaginal septum, parametria. We get diaphragm also involved. So when you are, my colleagues used to say, Madam, deep endometriosis is rare. You people will agree with me. Nowadays, we see so much of deep endometriosis. I don't know, our understanding has improved or it is becoming more and more common, but you commonly see cases of deep endometriosis. So these are the questions. When should you operate? Especially deep endometriosis, one should not jump operating. And there are very clear guidelines now. If the patient has symptoms, because there is serious risk of severe injury to vital organs, like bowel, like kidneys get knocked off because of ureteric, bladder, there is hematuria, then you of course have to intervene. And there is some literature coming because surgeries are improving, surgeons are improving. The deep endometriosis may improve fertility to some extent, but I don't want to generalize this statement because these surgeries are really level 5 surgeries. And Ramni will agree with me, even we pray to God when we are going in these patients. So surgeries are conservative. More and more girls are getting married late. So we are, we are forced to do conservative surgeries in deep endometriosis because once you do complete and remove ovaries, there are higher chances of their settling. But now we understand that girls are getting married, you have to do more and more conservative surgeries. That further puts challenge on us to, be conservative and give her results. This question now doesn't arise because by the virtue of laparoscopy, the moment you put the scope and you see the POD, so sometimes, it becomes easier to dissect because of magnification, because the area you see with the scope, and there are so many advantages of laparoscopy. We all know it is a challenge. Advanced laparoscopic surgeon with lot of training is required because we gynecologists are trained on everything, but for bowel, the moment you take consent from the patient that there may be bowel injury, you lose that patient. She just runs away. So, and that possibility is always there in deep endometriosis. So when you see a case of deep endometriosis, who comes to you either with dysphagia, severe dyspareunia, hematuria, bleeding through rectum, severe pelvic pain, then you assess. So how do you assess when you clinically suspect that this patient may have deep endometriosis? As somebody, Naren, was very nicely discussing, history and correct examination really helps you. History is very, very important. Examination of especially per speculum examination, number of times you see nodule in the posterior vaginal fornix, which even imaging, the eyes cannot see what the person, brain does not know. And that is very true in endometriosis. The person who is doing imaging has to know what exactly is going for. That is the reason people who are doing their own TVS, they are sometimes very good. But majority of people, those who do not do their own ultrasounds, MRI is also very good. MRI doesn't carry if you just get it done. Patient goes, gets it done by a center which is cheapest. That's very sad. You don't get any information. The person who knows deep into what he is going to look for. Sometimes they put gel, sometimes they put dye in the rectum, because knowing involvement of rectovaginal septum, to my mind, is very, very important to tailor for us to make whether we are just going to shave off the lesion or going to do discoid or going to do segmental resection. So imaging is very important. MRI gives you a better, but if you are doing your own TVS, people are better at, but TVS is, observer dependent. So that really depends. What is the pre-op preparation? It's very, very important. Bowel preparation, there is now a lot of controversy. Some people don't prepare at all. Some people go for very expensive. Whatever you do, I have one thing to make, that we have stopped giving Peg-Leg or what you call Oxolite. That really makes her purge. And if there are liquid contents and you open the bowel, you are in a worse situation than you would have. So otherwise, you give Rafagat and all those things which we are giving, that is okay. So consent taking is, as I said, it's very important always to take consent in cases of deep endometriosis for bowel injury, bladder injury, ureter injury. It's very, very important. So consent is very important. And bowel preparation of patient, explaining. These are not the patients like TLS, they came and you put 3-4 patients in the list and she goes. You have to involve a multidisciplinary team. Positioning is very important. They are often long surgeries. So in all theaters now we have these landscapes, then keeping pneumatic compression so that DVT is less. So patient positioning, patient pre-op preparation, these issues are really, you have to go deep into it personally if you really want your results to be optimal. Then comes the question of identifying in OT. It may be a kind of iceberg phenomena where you just see and think, oh, this pelvis is not bad. And when you open retroperitoneum, you realize, my God, there is so much of deep endometriosis. So your pre-op good imaging and your understanding of the subject. Then while we are discussing principles, I think I will skip these slides and go to some video clips of my own cases I want to show, and I want to really learn from your comments. Steps of surgery, it's very important that, at least in my practice, we make a lot of manipulators, manipulator in the vagina, manipulator in the uterus, manipulator like in the form of a sponge holder in the rectum, and assistant showing. They really help you in delineating anatomy and doing safe surgery. So ovariolysis, many people, suture the ovary, suture the uterus because you want to operate in the POD. They are very good things. They are very good things, and not every person is happy. Every surgeon has their own ways, and I have my own ways. So what you start is go from the normal area and come down to abnormal area. These are the basic principles of this surgery. And secondly, you can see this diagram here. Whenever you go in AAGL, they just keep teaching opening the spaces. Knowing anatomy of the retroperitoneum is the crux to do endometriosis surgery. Paravesical, pararectal. Thankfully, we are from the era where we used to do a lot of advanced laparoscopically. So you have to learn retroperitoneal anatomy. Then only you are comfortable operating these cases. Otherwise, you will always be scared what is there. So paravesical, pararectal, and then knowing the nerve neurology, neuropelviology, so that you don't damage nerves. Otherwise, you may do more harm than good to your patient. So these are very important things when you do these surgeries. And rectovaginal space is very, very important. I think I'll just show 2-3 videos, and then checking for the rectum and bladder integrity. Don't think you are a big surgeon. Always check for integrity. Even in 1 in 100 times you pick up something, it is worth it, because if the organ, vital organ injury goes unnoticed, it leads to patient really suffers a lot. And nowadays we are in so much of medical legal, and you really don't want a patient to have serious complication. So these are the ways. Sometimes we push air, but I personally am not happy because I never feel comfortable. So we always put some fluid in the pelvis, and we, with the soft instruments at the level of brim, and then we check. Bowel integrity is to be checked of all rectovaginal nodule surgeries. So these are still, I would say, major problems. Uterosacral, cardinal ligament, sometimes you need to excise a part. Ureter involvement may be of many times. Majority of times it is the extrinsic pressure. Please, in a case of severe endometriosis, always get her kidney function done. Sometimes we get DTPA scan because later patient may say that you have injured her kidney, and number of times it comes out that the renal function is compromised. So it's very important beforehand what exactly is the health of kidney and the vital organs. So I think I'll finish off with my time. It is just 15 minutes, so I'll just go to then when bowel endometriosis, doing these cases for years, I have learned many things by my mistakes or improving understanding. We mostly believe in shaving the rectovaginal nodule. What I personally do, I'll show in the video. We cut the nodule half towards uterine side, half towards, and then we shave. We feel more safe that way. Everybody has there. So this is a patient where we did TLH for severe endometriosis. And as you see, there is a nodule. And some people say, oh, nodules are very rare. It's not so. Once you start doing, and these cases keep coming after many, many surgeries, it's not uncommon. See, many times surgery is just being able to operate in the correct plane. Once your patient starts bleeding, tell yourself you are not in the wrong plane. So, and in these patients, because they have multiple surgeries and near rectum, majority of time we use we check the bowel at the end of the procedure, but I wasn't satisfied because our MRI in the theater was showing there is lot of a big nodule. So we thought pararectal area is very safe to open. Ureter may be open the pararectal area. And traction, counter traction is key to safe surgery. And baby steps. I take time, but so they should be done with all. You should not keep that day many cases. And pararectal opening. See how nicely you can see these areas. Open these areas, release the rectum if there is dysphagia, release it nicely. Don't damage the nerves here as 2, 3, 4. Often it, and then somebody is showing me to the rectum. So there is just a sponge holder. Make a good team for these cases. So, and this is what after all adulasis, all removal of disease, this is the pelvis, and the patient gets cured. Especially when nowadays we are leaving their ovaries many times if they are normal. So you have to be still more careful, because once you leave ovaries there and you leave residual, then symptomatic relief may not be that much. And this is a very nice case, and you see, do nice per speculum examination. Many times you will see this is a case who was just married. She came to me. She said she has severe dyspareunia, and there were all these blue chunks protruding in the posterior fornix. So always yourself do. MRI didn't pick it up. So see them carefully. And this was the laparoscopic view. And now the task ahead is removing that nodule. Some people may remove mark from below. I don't feel safe from below because in laparoscopy you see everything. And do it with, loving, tender care, gradually, baby steps. So release adhesions. The task ahead is to remove vaginal nodule. Hi. I'm at home, but I'm in a lecture. In 10 minutes, I'll be free. No problem. Thank you. So this is what release both the ovaries. And then you will see in a minute how easy it becomes once you have a good team. Somebody is pushing the posterior fornix with a sponge stick, and I can, see. And as I said, I cut the nodule often in the middle and then release it from that side and this side. That way I feel safer. So it is up to the surgeon how they want to. And of course, no energy when you have rectum too close, because at that time you may feel it is intact, later it may give way. And this is what is, and now see how nicely somebody is showing me through posterior fornix. And pararectal area dissection is very, very important, and it is quite safe. Now I am into pouch of Douglas upper part. So some person is from below pushing with the fingers and showing me the nodule exactly. And that is how it becomes safe to just cut it in the middle and remove that nodule. Sometimes we mark that nodule with, this is the vaginal nodule after reaching, releasing the rectum from there, then opening the nodule from above and release the nodule in full thickness because it is protruding through vagina. Otherwise this peronia will not go away and they keep having spotting. So these are the patients. This is complete removal of vaginal nodule. She didn't have rectovaginal. She just had this vaginal nodule you saw, but you have to release the rectum completely to reach, and then you can suture from below. But as I said, from above, when it's your comfort level, and then suturing the vagina back. And the patient became pregnant. She was not even able to have intercourse. So these are the issues. So this is the end view. Since she was very young, wanted to conceive further, so you are saving her ovaries. And yeah, when you have younger patients, and there is no shame in having a colorectal surgeon on guard or making urologist friends, because these people are handling these cases day in and day out. But let me be honest, Ramni will agree with me. If you hand over your case to a rectovaginal or urologist, they won't be able to. You have to do dissection yourself. And then for, final work, or if they have to do stapler or thing, then you have to call. Otherwise, if there is onco-radical surgeon, see how nicely the planes are preserved. You have to open them very diligently, very carefully. And this opening the rectovaginal space is, to my mind, is very important, very safe. Ureter goes lateral, you see pelvic nerves, and you can finish your work with lot of confidence. And if we open the bowel and for discoid and for end-to-end, this is all the nerves. So you have to know the nervous connections, and it really takes years to understand and save these nerves. And if you start trying, you will be able to. So this patient again was for fertility enhancement. And don't do these surgeries, do incomplete dissection, leave them, because the next person who will go there, that person will still have problem if retroperitoneal dissection has been performed and the patient is left without complete surgery. So unless you are very sure you have good team, just don't. And if they don't have symptoms, not necessarily every patient of the deep endometriosis requires all these kind of surgeries. So it is basically symptoms. Basically, if they have symptoms of dyspareunia, dyschezia, often we get their sigmoidoscopy, colonoscopy before, because often they will complain that they are having bleeding through rectum. Urinary tract, everybody keeps showing videos. I'll just show this patient, and she had 7 centimeter endometrioma, and I have wonderful urologist. So because it was so near to ureter, so I said we will have to implant her ureter. He said, madam, let us assess, and he is so good in his work. So after let us do like section. Part I'm doing paracycle, opening all the spaces since she was for TLS. So if you do your work yourself in the last part, because if there is a perforation, it may go anywhere. So release all the adhesions. You will see in a minute. I'm completing my work. Then I said, okay, you try. You want to do TOR kind of procedure like PCRE procedure. You want to resect it, and we have now a number of patients who are really totally cured with this approach. So otherwise, a simple case away from ureter, just remove the nodule and suture the bladder back. We all keep doing. But when it is a big nodule, when it is near to the ureter, this is our in this hospital when I have come, we have started doing this, and a number of patients they are in long follow-up. So first I did TLH and see the bladder. It is the serosa is nice. There is no invasion of the nodule. It is just inside. So after TLH, after nicely dissecting the bladder, I handed it over to him. And these patients, whatever number we have done, and they are very happy, and ureter reimplantation is not required in these patients. So this is what, and now after this, he will be doing, these are the stents in the ureter. We don't stent ureters often because I don't think, and now he is doing through cystoscopy, resection of this endometrium, and the patient is, I think it is 2.5 years, he is doing very well. So every patient in endometriosis is a story, and you really have to individualize every patient, how with minimal invasion, with minimal damage, you can give her maximum relief. That is the aim, and it is tailoring the treatment. We are still learning. So these are some of the cases. Then we have lot of extra uterine like abdominal wall and umbilical. There is no site from where I have not removed the nodule. And recently I removed it from the inguinal ligament by the side of round ligament, and we did it. It's a beautiful video. Sometime if you invite, we will show. So endometriosis can be anywhere. It goes along the round ligament. It is often into the cesarean scar. It is in the umbilicus, and these are the, so if my time has finished, I'll stop here. Otherwise, so to conclude, adequate assessment is very important. Counseling is very important. Patient may run away, but I always tell them, in years I need a colostomy, but I don't know which patient I will require. And always take consent for colostomy, especially when bowel nodule. If the nodule is lower, involve colorectal because chances of fistula are higher. If nodule is higher, you will be able to do it. So it is the level where the rectum is fixed or where the rectum is not fixed that you tailor your surgery. Communication and having multidisciplinary approach is very important. You should have people around. Appropriate energy sources. Near rectum, we use just scissors. And a mobilization of rectum is very important. Always operate from the free area to the involved area. You will often be, happy with your surgery and taking up. It is all knowing your planes and being able to operate in the correct plane if you want to give good relief without injury, and systematic identification of all the pathologies, whether ureter is involved, rectum is involved. These are very, very important. And we believe in shaving, and majority of time we do shaving, and our data is good, but people are very, very aggressive. Sometimes I think some colorectal surgeons are very aggressive. Some gynecists are very timid. We have to be a combination of aggression and conservatism. When you are treating deep endometriosis, you should not just take away her nerve supply and things. You should be very, very, judicious in what all you are going to do. And suturing skills have to be very good, which nowadays these youngsters are so good. And this is the future. They are searching things where you can, make out how deep is that endometriosis. And thank you very much. Special thanks to Ramani and Asha Rao for this beautiful execution. And I can thank you for inviting me, and thank you for patiently listening.
Thank you so much, madam, for your excellent deliberation, and your videos are always treat to our eyes, very crystal clear view as well. And thank you so much. I request the chairperson, if you have some quick comments you can make.
Thank you so much, Alkaji, for that wonderful presentation. You really are an authority on DIE. Thank you so much.
Not at all. We are learning. We are all learning from each other, learning from our patients.
Alka madam, it was a mesmerizing talk and a very nice treat to the eyes. Thank you, madam.
Ramani.
Thank you for obliging us.
It's a mutual admiration committee with you.
Alka madam, is it a routine you put in a stenting for all DI patients?
No, I don't believe in stenting. So many days they have hematuria, and there is evidence in the literature that it doesn't decrease the incidence of ureter injury. So hardly ever, especially when we stent when kidney function is compromised and there is hydronephrosis and stenosis. Otherwise, in routine patients, we don't stent.
How do you decide between the dissection versus shaving in a deep-seated
This is
bowel?
very important. This is very important. Discoid. If the lesion is there, are clear-cut guidelines.
Ma'am, we can't hear you, ma'am.
Madam, you keep close to the mic. You keep close to the laptop. Yeah.
My lecture voice was okay.
Yeah, it was okay, but it was now and then it was waxing and waning. Your voice. Keep
During
close.
lecture also?
Yeah.
Yes.
Just
be close to your laptop, madam.
Yeah. So the question asked was, now it is clear?
Yes.
Dissection versus shaving.
So discoid excision. The guidelines say if it is more than 4 centimeter, or if it is involving more than half circumference, or if the lesion is going very deep into muscularis, or it is up to the mucosa, or if it is bulging and it is a smaller lesion, then a smaller lesion means, otherwise third is you have to do that you call the colorectals and they do end-to-end anastomosis dissection. That also we do, but it is for a very big lesion. Majority of time we do shaving. The shaving, but your rectal mucosa should not be involved. It should not go deep into muscularis. Lesion should be smaller. But while shaving, if you open and if your bowel is good, contents are not leaking, and you suture, mostly nothing happens, but you have to be careful after that. We believe mostly in majority of patients in shaving, unless the lesion is very big.
Madam, I have, can I just ask for a patient for infertility, and you have just put in a scope for endometriotic cyst and endometrioma, and you have DIE. So which has come as a big surprise. A patient doesn't have symptoms. So till what level one should be doing the surgery?
Sudha, this is an excellent question. I keep getting patients who have multiple surgeries.
Madam, we can't hear you.
Pardon?
Yeah, you keep close to the laptop.
Am I audible now?
Yes.
Madam, if you look at the side, the voice goes off, madam. Please, please look in front so that we can hear you.
Sure. Now it is okay?
Yeah.
Yes.
I'm so sorry for my dancing. So the thing is, Sudha has asked a very, very important question. How far to go? I want to say, Sudha getting patients who are not necessarily operated. Just brain and then it becomes more difficult to give better result in these patients because there are androgenic added adhesions which create further problem. Having said that, the question asked is that how far one should go. Again, the literature is very clear. If a patient is asymptomatic, don't unnecessarily go for DE surgery. But in the latest 2022 journal of JMIG, there is a very nice article, and they have taken 8-10 articles. They say chances of fertility are higher even if you have done incomplete DE surgery. But please read in between lines, all those surgeons are top line endometriosis surgeons. In an average hand, you may not be able to give that result. You may lead to more injury. You may lead to more adhesions. So, and thirdly, Sudha said that it comes at a surprise. It should not. A case of endometriosis should be nicely worked up. If she goes away leaving you, let her go. Often we get MRIs done because, and from a center, from our center, where they are able to tell you the real involvement of rectovaginal septum. because many times you will see it is just false positive and you get nothing in the OT. Or if it is false negative and there is a very big nodule. So your MRI should be reliable. And for that reason, I have made friends for years at All India Institute with MRI people. And it took me long time to learn rectovaginal involvement. So these things are very important. I know some of the colleagues are doing very good TVS. Our MRI people, they put gel. When I tell you, have to tell me how much is the involvement, how deep is the lesion. Then they really have to do MRI with lot of expertise. And it is not a good idea to just take a patient of endometriosis without going deep into, especially if you suspect in your PV that she may be having DE, because getting DE on the table, even for a senior person like us, it's very difficult to obtain consents, because whenever we operate DE, we take all the consents from the patients, because you don't know how deep you will have to go, whether bowel will open, and once bowel opens, you have to tell a remote possibility of colostomy. Then these people run away. The moment you name colostomy, they just vanish from. Whatever it is, you have to take all the consents. You have to think of the worst situation and then go in. And if it is just infertility, no dyspareunia, no dysphagia, often you may not be going for such deep dissection and disturbing her nerves. But now literature is coming that since the surgeons are better trained, people are doing only endometriosis centers are there. Once they go in, they don't want to leave DE and they finish the job. It depends on the experience of the person who is doing. Even a very experienced person may not be properly trained in DE. So we have to train, and I think that is very, very important, that don't do damage. And but now the literature is coming that you remove DE and the pregnancy rates are better.
Yes.
Every patient is to be individualized. The patient comes and tells you that I'm having severe dyspareunia. Do a nice per speculum examination. She may shout, it's paining. See her posterior fornix. Number of times vaginal nodules. That unless you remove, she's not going to settle.
Thank you,
Ma'am,
madam.
after the bowel surgery, how do you check the integrity of the bowel, ma'am?
This is a very good question asked to me. Everybody in the literature, our colorectal.
Madam, we lost your voice again.
Could be at the intended also.
Ramani, madam, Dr. Pramathis is not joined, so should we conclude the session?
We will conclude the session because already we are learning late.
Yes, we have lost madam's voice totally.
Madam, your voice is not totally audible.
Yeah. So can we ask the chairperson to conclude, make a concluding remark, and we go ahead with the second session?
Yes, madam. Yes.
I'm not audible?
Yeah, now intermittently you are audible.
But
But
the
the
lecture
best.
also, this was the
No,
problem.
lecture was okay. Lecture was okay.
Lecture was excellent.
Lecture was excellent and we could hear you very well. But
so I was telling, I always check by putting methylene blue through rectum, light methylene blue, and blocking the sigmoid at the level of the promontory. So once it balloons, I feel very satisfied.
Okay.
So
Now,
thank you so much, Dr. Alka, for that wonderful discussion.
Thank you.
so much, and sorry for the voice disturbance.
Thank you so much, madam.
And
So
thanks
thank
again,
you very
Asha,
much.
and I can see so many stalwart. Ruma was here, and Sudha is there, Sneha is there. Thank you for
Thank you so much, madam.
Thank you, madam.
Have
It
a
was
nice evening.
wonderful. It was wonderful learning from you. Wonderful surgery. Thank you very much. And thank you for the opportunity.
Thank you, ma'am. Thank you for the wonderful session and for the opportunity.
I really enjoyed. For Ramini and Asha, always there.
Thank you.
Your
Thank you,
program is
madam.
very good.
Thank you.
Your program
Thank you so
is
much.
Wonderful, wonderful.
Thank you. Thank you. Thank you so much.
Thank you.
Move on to the.
Thank you once again.
Yeah. Snega, move on to the next session.
Yes, yes. So because we do not have Dr. Pramathis Mahapatra, we conclude this session and move on to the second session now. And as Dr. Agini Agrawal and Dr. S.
Chitra is there, I think.
Has she joined just recently? So we welcome you, Dr. Chitra.
Ragini will join shortly, I believe.
Yes, I just talked to her, but she's busy. So we let us hope that she joins in some time. So by the time we can hand over to Dr. Chitra to start
Chitra,
with
unmute
the
yourself,
first
Chitra.
session. Yes.
Yeah, fine.
Thank you very much for having me here along with you all for this ICOG masterclass program. And we move on to the second session now. And we have, Doctor. So this will be a part of the first session in this talk, right?
Go behind.
The second session, I need to have Dr. Damodar Rao.
Yes,
Unmute,
Chitra, you can,
Present,
yeah.
ma'am.
You can introduce him in short
Yeah, he's
and
there.
then, yeah.
Can I have his CV, please? He'll be talking to us about ureter in endometriosis, the most notorious thing to handle with when we do surgery, whether it be open or lab. We always have this ureter coming in between all those additions, and we learn from the expert on how to handle it when we come across such a situation. Dr. Damodar Rao is a consultant endocrinologist, endogynecologist, and a reproductive medicine at Rao Hospital, Coimbatore. He is a joint secretary of Tamil Nadu IAGE. He's been the managing committee member, National IAGE in 2024, recipient of Shan S. Ratnam Young Gynecologist Award for the year 2022 at AFOG and FOGSI Future Award, and Yuva FOGSI South Zone 2019, and Best Endoscopy paper was awarded to him at AICOG 2015. Of course, we have been hearing him and seeing him do many times surgeries. So here we have the expert to tell us about how to handle the ureters in endometriosis. Over to you, Damodar.
Thank you, ma'am. Thank you for that kind introduction. I'd also like to thank ICOG and Ramani Madam for this opportunity. And is my screen seen?
Yes. Just make it slideshow.
Full, yeah. Is it on full screen?
Yes,
now?
make it full.
Yeah. Okay. So my topic today is on ureter and endometriosis. I didn't want to make it a completely, like a urogynec or a urology topic. So I thought I'll talk to you more about what we gynecologists should know about the ureter and endometriosis. Of course, I'll be also talking about endometriosis of the ureter later on. Endometriosis affects about 10% of the female population, and endometriosis of urinary tract is rare, but perhaps less so than previously thought. The ureter, if you look at it, just a short, brief course in anatomy, it's about 25 to 30 centimeters in length, and it traverses along the psoas muscle, and the pelvic brim, it crosses over the bifurcation of the common iliac artery, and it moves from lateral to medial, courses down just lateral to the sacrum up to the level of the internal os, then deviates medially, lies next to the internal iliac artery and passes below to the uterine artery. At this level, it is 2 centimeters lateral to the internal os. When it comes to endometriosis and the ureter, they say that the torus of the uterus, that is probably the level of the internal os, that's where the DI lesion is also there, and that's where probably the ureter also gets involved. So if you look at the course of the anatomy, course of the ureter, you can see it crosses over the pelvic brim over here, and then you can see the ureter running under the uterine artery over here. Probably it is at this level later on, distal part of the ureter, where it gets involved during endometriosis, and we should have good knowledge about this part of the ureter. So it will be divided into ureter in endometriosis and of course endometriosis of the ureter. Coming to ureter in endometriosis, because this is what as gynecologists will be commonly coming across, especially in grade 4 endometriosis. Localizing the ureters is very, very important because of the distorted anatomy. Uretrolysis is now accepted as an obligatory step for freeing the ureter from the endometriotic nodule and adjacent tissues to prevent any injury to the ureter, because it's difficult to predict how the ureter will travel. It can get pulled medially sometimes, it can get pulled laterally sometimes. So uretrolysis really helps in identifying the course of the ureter. Preoperative assessment, of course, is very, very important. We have to do a good ultrasound scan. I think that one is very accepted as the first line of screening. Is a very good TVS scan is pretty good. And if you have a doubt that if the ureter is involved, or if there is some dilatation, or you see a change in the size of the kidney, then definitely go in for an MRI, and also go in for a CT screening where you do a renal, where you can check the renal function. They inject a isotope into the vein and they check for the excretion of the isotope from the kidney, and they give you renal function. Many times these people can in the long term go in for silent loss of the kidney also. So, you should have all this at the back of your mind when you're dealing with ureter and endometriosis, or endometriosis in general, right? So looking at the ureter is very, very important. And based on this assessment, your intraoperative procedure will change, whether you're just going to do a ureterolysis or end-to-end anastomosis or ureteroneocystotomy. So based on what you find preoperatively. And it does not end with surgery. These patients will always be with you under long-term follow-up. You have to have a short-term assessment. You have to check the renal function, and then also a long-term assessment, right? Many times, these patients, if they are not followed up, they can again have recurrence, and patients can lose kidneys. So it's very, very important to have them under follow-up. So coming to very simple things like, usually the implant where you'll see it along the, even in grade 1 in endometriosis, you'll see it along the uterosacral and or just lateral to it. The ureter is usually running in that area. So nowadays it is, instead of burning out the lesion, it is advised to excise the peritoneum around that area. And the knowledge of the course of the ureter is very important. And you should do a good ureterolysis and remove the peritoneum around that area. So by doing this, you're reducing the pain and reducing the chance of recurrence by quite a bit, rather than just burning out the lesion, because endometriosis is a tip of the iceberg disease. You really don't know what lies beneath. So it is always good to remove the peritoneum in that area. Coming next is what we otherwise commonly do is the chocolate cyst, right? So back in the day, we would just do, separate from the ovarian fossa and go do a cystectomy and come out. But nowadays, it is always good to know again where the ureter lies. So doing a good ureterolysis and finding out the course of ureter is very, very important. Why is it important? One is the ureter can be very closely applied to the ovary. And number two is, after doing the cystectomy, many times you will have a lot of bleeding of the ovarian fossa. So to control the bleeding in this area, you will have to apply some amount of energy. So knowing the course of the ureter will really help you, find out where exactly you can apply some amount of energy and where you can't. And at the same time, it also helps us remove some amount of peritoneum in that area. So removing the peritoneal implants has become a very important part of surgery nowadays. And for that, you have to do a ureterolysis. So knowing the course of the ureter is very important. It can be, like I said, sometimes it can be pulled laterally, sometimes it can be pulled medially. Here you can see that after doing ureterolysis, it is lying more on the lateral side. Here there's the peritoneum being removed. And after doing all this, there was some amount of ooze. And to control that ooze, now because I know that the ureter is on the lateral side, you can judiciously go and apply energy on this area and not worry about damaging the ureter or any other structure, right? So ureterolysis is important, in making your surgery safer. And you could also do a complete surgery. Something new that has come into the market, not very new, but something that is sort of new, is using ICG in your surgeries. You basically stent the ureter, and then you push in the ICG dye. About 7 ml of diluted ICG is pushed in, and then you remove the stents. So you don't keep the stent in place, you remove the stents, and then there are some cameras which can, detect this ICG, the dye. And then you don't have to really do a ureterolysis to identify where the ureter is. But the only disadvantage of this is that when it is really bloody and messy, or there is dense peritoneal implants, you really can't see the ureter, and then you'll end up doing a ureterolysis, right? So this is useful in very mild cases, but in cases of very severe endometriosis, frozen pelvis, sometimes it becomes difficult to identify ureter with this ICG technology. Next is the We have to know the ureter while doing the hysterectomy, especially in case like this where you have, deep infiltrative endometriosis or grade 4 endometriosis. There is something called a so-sure technique, where basically you do a sigmoid mobilization, ovariolysis, and exposing the ureter. So if you dissect out the medial pararectal space, Madam also spoke about it, Alka Madam spoke about it in the previous talk. Dissecting out the medial pararectal space, you're able to see the ureter over here, and the rectum is here on the medial side. This is also called a space of Okabayashi, and the nerves also run in this space. So dissecting the ureter and knowing where exactly the ureter is going is very important. Sometimes it can be pulled laterally, sometimes it can be pulled medially. That is the main reason you do a ureterolysis in such cases. This is a particularly interesting case where ureterolysis, you always do a ureterolysis usually from medial to the IP ligament, and that is called the endometriotic approach. If you do it lateral, it is called the oncological approach. So here the ureter kind of looked quite thick, and on the scan there was no hydroureter or anything like that. Later on we found out that it was a double ureter actually. So, and it was running quite snug to the rectum, right? So dissecting out these spaces is very, very important. There you can see both the tubes, individual peristalsis of each tube. You can see the vasculature of the ureter also. That is also very important. Otherwise, you can land up with necrosis. So dissecting out these spaces makes this surgery a lot safe and saves you from trouble. What about stent placement? Again, this was also discussed previously. Again, stent placement pre-operatively is usually not placed. I don't do it. Sometimes if you think there is some thermal injury there, then you can place a stent. Probably back in the day when you were doing open surgeries, then stent was useful because you could palpate. Your vision was not so good, so you could at least palpate the ureter if required. But nowadays, in laparoscopy, we generally do not prefer to stent pre-operatively. If required, you only stent post-operatively. And then you keep it for about 4 weeks in case you think there is any thermal injury. So that was mostly about ureter in endometriosis. That is about the course of the ureter, how to do ureterolysis. Coming to endometriosis of the ureter such, if you look at the incidence, if you look at incidence in the urinary tract, bladder, ureter, kidneys, urethra, after the bladder, which is about 40%, next is the ureter. The most common site is ureter, which is about 5%. In this, if you look at it, the left side and the distal part is most common, 56%. That is because of the presence of the sigmoid over there. That is one of the theories. And on the right side, 35%. And bilaterally involved is about 9%. It is seen in 30% of urinary tract endometriosis. There are two major types. You have the extrinsic type and then you have the intrinsic type. Extrinsic is about 80%, and it involves the the peritoneum, uterosacral, all are involved. Then that is called extrinsic. The ureter as such is not involved. And when the muscularis and the uroepithelium is involved, you're called intrinsic. Okay, extrinsic is more common, about 80%. There have also been studies which says that when the rectovaginal septum, the nodule is more than 3 centimeters, there is more involvement of ureter, and there is 7-fold greater chances of having ureteral endometriosis. And patients with rectosigmoid endometriosis have a 22-fold greater chance. Right? Symptoms asymptomatic in 30%. You have to have a high incidence of suspicion in case of ureteral endometriosis. Urinary symptoms can be there. They might have other non-specific symptoms of endometriosis like dysmenorrhea, pelvic pain, etc. But if there is urinary frequency, urgency, blood in the urine, pain in the flank area, then definitely think of ureteric endometriosis, most probably intrinsic. And many times you have to have a high suspicion of this. I keep saying this because there can be silent kidney loss, right? So coming to ureteral endometriosis, of course, history, like I mentioned, you have to ask for symptoms, and then you got to do the ultrasound at the first line, then MRI, and then intravenous isotope renography to check for renal function. And laparoscopy is the mode of choice. Usually medical management really does not have much of a role in cases of ureteral endometriosis. It is laparoscopy, which is the main mode of treatment. Even ureteroscopic management per se with laser or balloon is not good because of the chance of, recurrence is quite high in these procedures. So laparoscopy is what is preferred. So the three methods are, one is the least invasive is ureterolysis. If the lesion is less than 3 centimeters and it is not associated with hydroureteronephrosis, then you go ahead and do the ureterolysis. Intrinsic endometriosis is a contraindication for ureterolysis, right? It has a high recurrence rate of about 16% and possible need for intervention later on and requires close follow-up. So if you do a ureterolysis, mainly if the lesion, what you see is less than 3 centimeters and it is not associated with hydroureteronephrosis. Right? This is a particular patient where I just wanted to show you what a hydroureter looks like. So there it looks quite small, but on further dissection, you can see that it is quite enlarged, right? There you can see the whole ureter, which is quite big. So in such cases where there is no real constriction anywhere, or there is a constriction lower down, and there is no intrinsic endometriosis, you can just do a ureterolysis and leave it alone. And that's all that is required. What if little more is involved? If the lesion is longer, more than 3 centimeters and below the level of iliac vessels, and if there is hydroureteronephrosis also, then your options are either end-to-end anastomosis or ureteroneocystotomy. Ureteroneal anastomosis is preferred if the ureteral stenosis is limited to the ovarian fossa and distal ureter can be preserved. That is very, very important. If the distal ureter can be preserved and the lesion is small, then you can do an end-to-end anastomosis. But if the lesion is very, very, it is at the vesico-ureteral junction, or if it is more than 3 centimeters, then you have to do a ureteroneocystostomy. These are videos of the same. Due to shortage of time, I'm going to skip these videos. I think there are slides in which are probably more important right now. There are questions also on the same, so I'll just go to these slides, and then I have just one more slide after this. When do you do a nephrectomy? That is, if the kidney function is less than 10 to 15%, then you have to get in a complete multidisciplinary approach, and you consult with the urologist and probably do a nephrectomy in such patients, right? So if you look at, if you want a chart for ureteral endometriosis, this is my last slide. If you suspect ureteral endometriosis, then you do a renal scintigraphy. And if the patient has, if the renal function is less than 10%, and along with that, she has recurrent UTI, recurrent pyelonephritis, then you have to think of nephrectomy, like I mentioned in my previous slide. But if the renal function is more than 15%, this is most of our patients, and there is no evidence of large macroscopic infiltrative endometriosis in the ureteral wall, I'm sorry, spelling mistake, then you go and do a ureterolysis. This is what most of our patients will require. But if you find that there is macroscopic infiltration of the ureteral wall or moderate to severe ureteral dilatation or hydronephrosis, then you have two options. This is better if you do it, with a multidisciplinary approach with the urologist. If there is a short extent of damage and the lesion is less than 3 centimeters and there is no evidence of disease in the proximal ureter, you can do a ureteral resection with end-to-end anastomosis. If it is a larger lesion, 3 centimeters or more, and distal ureter is involved, and if there is severe hydronephrosis, then you have to look at ureteroneocystostomy. Thank you. This is my last slide. I'll be ending it with this slide.
Thank you, Damodar. Thank you for that excellent talk.
Thank you.
Somebody on the chat box was also asking how to recognize intrinsic involvement of the ureter. Even I had the same doubt. How do you diagnose that?
Yeah, one is with the MRI, you can detect if it is involved. Another, to confirm the same, you can do a ureteroscopy itself, and then you can see the lesion if it is involved.
That's what.
So
the first thing is only your suspicion. So after you suspect this, either if you think it is outside some strictures there, then you go and do a laparoscopy and find out if it's extrinsic, or if it is intrinsic, then you have to do a ureteroscope as well. Okay, thank you very much. Thank you very much. I'm sure it's a tough thing. Now with all these self-illuminating stents and all that, it must be easier for you to now at least identify the ureters easily. No?
It's not really recommended, ma'am, because these self-eliminating, I don't prefer stents because it makes the surgery tougher. And they say there's a higher chance of injury also because the quality of the ureter, decreases. But if you're doing open surgery, then maybe stents are useful because your vision is not the best. Maybe you go to the patient and then stents are.
That's what all of us used to do. We used to stent it pre-op before when we were doing open, but all with laparoscopy, I thought this would be more. Okay. Thank you very much. Thank you very much for that excellent talk. Can we move on to the next, Neha?
Yes, yes.
Neha, yes. Can we move on to the next?
Yes, yes, definitely.
Okay. The next would be Dr. Ruma Sinha. Ruma Sinha, she'll be talking on total laparoscopic hysterectomy in endometriosis. Welcome, Dr. Ruma Sinha. Can I have her CV, please? Yes. She's a senior consultant gynecologist, laparoscopic and robotic surgeon, Apollo Health City, Hyderabad. Founder, President, Association of Gynaecological Robotic Surgeons of India, clinical lead gynecologic robotic surgeon in Apollo Group of Hospitals, honorary professor, Apollo Hospital Education and Research Foundation, conjoint associate professor, Macqueen University, Sydney, Australia, distinguished clinician, Apollo Hospitals. She is also in the editorial board member for Gynec Robotic Surgery Journal, board member of Asian Society of Gynaecological Robotic Surgery, mentor, proctor, and intuitive surgical MARS fellowship in Apollo, FOGSI Endoscopic Center. She's the head of the FOGSI training center. We welcome you, Dr. Ruma Sinha, and waiting to hear all the tips and tricks of TLH in endometriosis.
He is also a very, very active member of Endometriosis Society of India.
Oh, good.
Welcome, Ruma.
Yeah, thanks. Good evening to everybody. I have a little bad sore throat, so I may cough a bit. But thank you so much, Dr. Ramani, Dr. Asha, and the whole team of ICOG for giving me this opportunity to speak on TLH today. And I think it's an excellent idea to do this course on endometriosis over 3 days in the evening. And I'm sure a lot of doctors are benefiting out of it. I'll just share my screen. I have very few slides, and I'm just going to talk about how we can manage and do TLH in the setting of an advanced endometriosis. Now, we all know 2 brilliant talks have just finished, and I was very keenly listening to them. Dr. Kriplani, as well as always exemplary, and Damodar gave excellent tips about ureter in endometriosis. Well, we just need to understand why TLH. When we talk about TLH in an advanced endometriosis, why are we worried? Because TLH, when it is combined by deep infiltrating endometriosis, the surgery becomes lengthy, it's difficult, and it's potentially dangerous, as both the speakers before us have spoken, that you can lead up into problem. So a radical hysterectomy approach is important, and that's what I'll actually speak about this concept here today. Extensive dissection of retroperitoneal spaces, Dr. Kriplani also mentioned about it. Ureter, bowel, bladder, and preservation of the autonomic pelvic nerves is your goal in these surgeries. The fibrosis that occurs because of the endometriosis pulls the tissues either medially or laterally towards the pelvic wall because of this disease and causes difficulties for you. It completely obliterates the normal dissection planes. So what do you need to do? You need to have the knowledge of retroperitoneal spaces. You need to have a meticulous plan before we enter the theater. And of course, you need to have advanced laparoscopic skills to reduce the risk of complications. So let's just start with the first video, which I call as a tailored radical hysterectomy in a patient of endometriosis. Now look at this patient. The game always in endometriosis, especially when we are talking about hysterectomy or clearance of endometriosis and infertility, is posterior compartment. Take time to evaluate completely what is it that is in front of you. Now, looking at this patient, it may look, oh, is this just endometrioma, and we can proceed further. But go stepwise, and that's what is, Damodar also mentioned about something called so sure. Is a stepwise technique in which the first you always begin by mobilizing the sigmoid. You may feel, why do I need to go into that lateral pelvic wall when I'm doing endometriosis? But remember, ureterolysis is most important step when you are dealing with deep infiltrating endometriosis, whether it is TLH or whether it is a conservative surgery that you are expecting. Just like you say, the route to the man's heart is through his stomach. The route to DI is through the ureterolysis. Remember, you have to identify both the ureters right at the pelvic brim to be able to proceed further. So mobilizing sigmoid is the most important step, because this you can see, once you have mobilized the sigmoid, only then you can identify the ureter. That's the left ureter that you can see is just coming up in my pelvic peritoneum here. And I'm mobilizing the ureter away from. What am I going to do here? I'm doing hysterectomy with bilateral salpingophractomy. So I need to mobilize it medially so that my infundibulopelvic ligament becomes clear and I can take it. So there's where I'm going to take my infundibulopelvic ligament. That's the ovary which have freed a little. And I know that my ureter is in the leaf, which I now dissected medially. So it depends upon what you are trying to do. If you're trying to do something else, you need to retract the ureter laterally. So depending upon what your task at the moment is. The task here is hysterectomy with bilateral salpingophractomy in a patient of advanced endometriosis. The second thing that you must remember is that the lateral to medial approach. Don't jump onto the fire immediately. Don't jump onto the posterior fornix, because then you'll get into trouble. Go laterally, find your ureters, get your infundibulopelvic ligaments done, and then proceed. So you can see again, I'm bit by bit, that's my ureter. So that's the ureter here. That's the ureteric tunnel that I'm dissecting in. That's the whitish ligament kind of structure is the ureter. You can see I'm only tackling the left side right now. So I have actually finished my left side. I've done the infundibulopelvic ligament. I've opened my uterovesical fold anteriorly and pushed the bladder down. What am I in front of? Now I have the ureteric tunnel. I need to find out my uterine artery. There is one plane of thought where you can go laterally, do the uterine artery region, but sometimes in endometriosis that can become very tough. Because of the fibrosis and complete obliteration of planes, you might not be able to find that. So remember that there is an alternate as well, and that's what I'm trying to show here. So ureter is below. I'm keeping an eye on the ureter all the time, while then I'm going to take my Macken rods and then uterine. Once I finish my left side, I then come to my right side. Now, Damodar did mention that there is an oncological approach and there is a medial approach to do ureters. But I believe when we do endometriosis, I always use the oncological approach, because I want to go into the most clean plane to be able to dissect my ureter and get it as medially as possible. So again, I have opened my plane, if you can see, lateral to my infundibulopelvic ligament, identified my ureter, and then I'm taking my infundibulopelvic ligament. So remember, just taking infundibulopelvic ligament may not be the same, just a simple thing. Now you can see in my peritoneum, which I've now held with my forceps, pulling it medially, I can now identify my ureter on the peritoneum. Sometimes it may be difficult to find this because the peritoneum and the ureters are completely cicatrized. They are pulled to the uterosacral ligaments. So remember, don't tackle your uterosacral ligaments till you have really seen where your ureters are. Once you have done this, both the ureters identified, uterine artery done, then the only thing that is left is the posteriorly, the rectum. The rectal adhesion sometimes is easier when you are doing hysterectomy because you already have a colportizer there. You can use any type of colportizer. You can have the blue tube, you can have the Coke cup and Rumi manipulator that I use, or you can just have a swab in the posterior fornix, which will project. Like in this particular patient, we did not have a colportizer because sometimes the patient's vagina does not have enough space to push anything through. So just a swab in the posterior fornix is guiding me to open my posterior fornix because my rectum is down and I'm sure about that. So you can see the swab in the posterior fornix. And then once I open the posterior fornix, my rectum is down, my ureters have fallen laterally, and I go ahead and open my vault anteriorly. So that's how I will go on the swab just to open it. It's a simple process. It's not really difficult as far as you have identified your anatomy, know what you're looking at, safeguarded the vital structures, and went ahead and finished the hysterectomy. So that's the right ureter at the end. You can see the peristalsis, and then you can see the left ureter this side. Again, you can identify the peristalsis. And in the end, if you want, just quickly do a cystoscopy and confirm the efflux from both the ureters. So that's the video number 1, a simple way of how to do a radical hysterectomy, a kind of tailored radical hysterectomy for endometriosis. Since we also do a large amount of robotic surgery for the last 10 to 11 years, I will actually take you through one small video about robotic tailored hysterectomy. This has a voiceover I'll give my voice a little rest and I'll just run it for you. Technique of robotic tailored radical hysterectomy for stage 4 endometriosis. Surgery for advanced endometriosis is difficult because of adhesive nature of the disease. Class 2 modified radical hysterectomy reduces pain recurrences. It differs from class 3 hysterectomy as the uterine artery is transected at the level of internal os and not at the origin. 5 steps of tailored radical hysterectomy: sigmoid mobilization, lateral transection of endopelvic fascia, follow the ureters into the pelvis by bilateral uretrolysis, rectal adhesiolysis by developing pararectal spaces, and colpotomy with bilateral uterine artery desiccation and transection. A 39-year-old para 1 presented with severe dysmenorrhea and heavy menstrual bleeding for 10 years, associated bloating and painful defecation, dyspareunia exacerbated during menstrual cycle. The setup of ports is as shown in the picture. Foley's catheter and Rumi's elevator is used during the surgery. We start by step 1 of sigmoid mobilization. Reflecting the sigmoid from the lateral pelvic wall is essential to create the space in the pelvis as well as to do the lateral dissection of the ureter on the left side. Then the broad ligament is opened laterally as much as possible. In fact, the round ligament is transected close to the inguinal canal. The broad ligament is then opened anteriorly, reaching up to the fold of peritoneum of the uterovesical fold and dissecting the bladder sharply downwards. The concept of the surgery is to go from lateral to medial. So we try to lift the adnexa from the lateral aspect towards the medial of the pelvis. Here you can see the left adnexa is being lifted from the lateral pelvic wall and the dissection is being performed between the rectum, sigmoid, and the endometrioma. In this process, the left uretrolysis is being done, identified, and then proceeded anteriorly. Once the left ureter is identified, one is sure where your ureter lies, and hence the dissection goes smoothly. Clearing the pouch of Douglas by releasing the rectosigmoid adhesions is the next step that we perform, enabled to complete the hysterectomy. This is the left side endometrioma being lifted from the lateral pelvic wall, posterior from the rectum and sigmoid, as well as from the surface of the uterus. Once the left side is complete, we then proceed onto the right side and repeat the same steps. The round ligament is transected and the broad ligament is opened laterally beyond the IP ligament. At this step, the identification of the infundibulopelvic ligament as well as the right ureter is pertinent. The adnexa, again following the same concept, is being lifted from lateral to medial. The right ureter is being identified after opening the broad ligament parallel to the IP ligament. And once this is done, the uretrolysis is being performed and the ureter is followed up to the ureteric canal. Once identified, the right infundibulopelvic ligament is identified, coagulated, and transected. Posteriorly, rectal adhesiolysis progresses so as the rectum is then released from the posterior surface of the uterus. We prefer to perform the colpotomy at this stage so that the lateral angles of both the sides are clearly visible. Once the anterior part of the colpotomy is opened, we then progress to identify, coagulate, and transect the left uterine arteries. The colpotomy is then proceeded from left to posterior. The posterior colpotomy is in progress, and in the end, we come towards the right angle. The right vaginal vault angle is then identified, the right uterine artery is identified, coagulated, transected, and the colpotomy is completed. The vault is then closed in a continuous running suture using 1-0 V-lock. The AHL score was 47. The blood loss was 150 ml, no intra or post-op complication. She tolerated oral feeds in 4 hours and voided spontaneously. We recommend performing the tailored radical hysterectomy, class 2, in place of a routine extrafacial hysterectomy. ensures better excision of endometriosis lesions, and decreases the incidence of pain recurrence. Thank you. So both these in this video we discussed both these techniques had a slightly different technique of doing hysterectomy. In one, we did the uterine artery earlier before we opened up the vault. In this, we opened the vault, but then went ahead and did the uterine. Because of the use of a particular manipulator that we use, which is called Rumi manipulator, has a vaginal occluder. Now, when you inflate the occluder, there is no loss of pneumoperitoneum. So you can actually progress in a different fashion depending upon this. Last video that I will show you, which becomes a very important skill that you need when you are doing a TLH and has an advance. Now, you may have this kind of deep rectal adhesion in the posterior wall of the uterus in patients when we are doing a TLH. Tip 1, always use only cold scissors. Now, you can see there is a direct bowel attachment or to the posterior wall of the uterus. Use cold scissors. Do not use energy unless you are very, very sure. Because even if you open the rectum with a cold scissor, the amount of damage that you will do is much less, and it can be easily sutured. But if the damage occurs because of some electrosurgical equipment, then the area of damage is much more, and there is more chance of lateral having more thermal injury problem. Tip 2, err on the uterus rather than on the bowel. So if you have to cut deep into the uterus, it's safer than you are very, very close to the bowel. So this is how you can see I'm dissecting more on the uterine surface, trying to just leave a little bit on the uterus, on the bowel surface, rather than getting into the bowel lumen. So that is the tip number 2 that you must remember when you are trying to do. Also be expecting of sometimes collection in this area. And so beware of some unexpected thing as well. So when you are dissecting, you must suddenly find some tissue or some fluid that comes in, which you don't expect it to come. That's just an endometriotic collection there, not that the bowel has opened, because the content of the bowel is slightly very difficult. Then the next that can happen, what you need to do is keep both the instruments. That means the myoma screw, if you are using to track the uterus, and the bowel forceps, which you are using to hold the bowel. Keep close to the line of dissection. Now, this is a very, very important concept in surgery that you need to remember. Either you are doing ovarian cystectomy or doing any other dissection between two planes where the plane is not very clear. Keep the two instruments very close to the plane, and then you will be able to do. So you can see when I keep both, when I keep both very close to the tube, I actually am able to dissect even sometimes just blunt traction when in the right plane. And that's tip number 4. The last that you need to do, remember, is never leave your eye off the ureter. So you can see in this particular patient, after doing extensive adhesiolysis of the rectum, you always remember that that's the ureter there. That's the ureter there on the left side. So whatever I'm doing, I keep going back, checking, making the person showing my camera goes to and fro to keep showing me where my ureter are before I take even a single bite. So that is so important. That's the ureter you can see, and never lose sight of this while you are doing a deep infiltrating endometriosis, especially for your TLH. So I have just these three videos to show. I can take any questions if there are any, and that's all. So if there are any other questions that the audience wants to ask or the students in the group want to have in the chat, I will be very happy to answer. Thank you so much.
Thank you, Dr. Roma. That was an excellent video that we could see, and the wonderful explanation about how to go about dissecting. So all that we have to know is we have to be very thorough in the anatomy of the pelvis before we touch upon difficult cases. That's the most important thing. We have to time and again rehearse in your mind before you go into the real field of work, so that you are close to what you want to really do mentally, and then you perform what you want to really do. Appreciate it. Thank you, Dr. Roma.
Thank you so much.
Now, yes, we move on to the third lecture of this session. And we have Dr. Vidya Bhatt here with us to talk about pain management of endometriosis. And Dr. Vidya Bhatt is the director of Radha Krishna Multi-Speciality Hospital and IVF Center at Bangalore. She has conducted more than 100 live demonstrations on laparoscopy and hysteroscopic surgeries all over India. She's been an invited faculty at international level conferences to do live surgeries and lectures. She has conducted Endovision conference every year, which is focused on skill development and recent advances. has contributed to over 27 publications in national and international journals and contributed many chapters in many textbooks. She has been the president of Karnataka Society of Obstetric Gynaecology. She has been the Secretary General of Karnataka Society. She has been the president of Bangalore Society of ONG in 2013, Joint Secretary of FOGSI in 2013, ICOG member, Governing Council member of IAGE, etc. She has trained international students from Nepal, UAE, Maldives, Nigeria, and Sri Lanka, and made them all as skillful as she is. And over to you, Dr. Vidya. Tell us about how to manage pain in endometriosis. Daily problem with the OPD.
This introduction and your kind words. Share screen. I need to do with this. Well, Nikila, she'll know. Yes. Just give me a moment. I'm just having a little difficulty.
This is the presentation actually. It was there previously here. It is. No, not like this.
Press.
Yeah, we can see your screen, but you need to open your PPT.
Yeah, I'm just trying to open my PPT.
No, I think we have to do that.
Stop share.
No.
New share. Go to new share.
Vidya ma'am, I would request you to minimize this first and then open your PPT and then you go to the Zoom screen.
Okay.
Previously presentation was here.
Minimize this. Or here you have to share. Close that.
All options. No, you press that. Not
Double.
No.
Okay.
Share. How to put
Yes, you can make it full screen.
Full screen.
Full screen. Open with Microsoft.
Oh, yes, open the PPT first.
Yeah.
Yes, now
Yeah.
you can make it full screen and slide. Yeah.
Thank you for the nice introduction, ma'am. And I thank ICOG and Ramani ma'am and Asha ma'am for giving me this opportunity to share my experience in endometriosis. Pain management in endometriosis, when you say it is really a sort of a devastating thing when a patient comes to you with pain, because endometriosis, the main symptom is pain. Pain abdomen, intestinal disorders, pain in the back, that pain sensation in the leg, nausea, vomiting, and constant fatigue is the main problem. And what do you see when you just look into the history? There is delay in the diagnosis of endometriosis. The period starts at 12 years, but the pain is there. And then as the pain increases in menarche, they go to a GP. And by the time they come to a gynecologist, there is a lot of delay, about 5 years. And when the diagnosis of endometriosis is made, it is an advanced disease. So we lose a lot of time in treating these students or these girls in treating endometriosis. Now, what is the management in endometriosis, the present scenario? There is a paradigm shift in endometriosis treatment. That is, we encourage fertility preservation when it is necessary. The old regime was initially medical management and if required surgery, and in case of recurrence again surgery. But the current regime is when necessary, it is initially medical therapy, and when necessary surgical intervention. And if it is surgery, it has to be one surgery, and that has to be the best surgery. Now we know that endometriosis is not just to the ovaries or to the uterus, it is to the peritoneum, ovary, tube. And when you look at the Anzane's classification, deep endometriosis is there where you have the rectovaginal endometriosis, then the sacrouterine and the cardinal ligaments, and then the rectum. And of course, adenomyosis, bladder and intestinal involvement also is there. So just let's have a pelvic nerve supply study. That is the superior hypogastric plexus, which contains the sympathetic and the sensory nerves. It supplies the uterus and the extension of the aortic plexus. So the plexus divides into right and left hypogastric nerves that join the pelvic splanchnic nerve, that is at S2 and S4. The pain impulses from the uterus goes up to the sacral, these afferent sympathetic plexus, which are found in the uterosacral ligaments. So these coalesce in the midline as superior hypogastric plexus and travel to the dorsal ganglia. These pain stimuli are processed and then sent to the brain. So this is how that pain mechanism, this is the nerve supply of the pelvis, and this is where these nerve roots are stimulated, or the endometriotic nodules, they just engulf these nerves, and then that's where the pain starts. So the pathophysiology of chronic pain disorders in women with endometriosis, the brain morphology changes and lower pain threshold. That is the nociceptive pain, and then the receptive pain, repetitive pain. So this is inhibiting incoming signals. The sensitivity is incoming signals is increased. So the nociplastic pain is always there, and the expansion of this nociceptive field is there in endometriosis because of these all implants, and there is spinal hyperanalgesia, chronic pelvic pain, and pelvic dysfunction also you see. But what is the pathology which happens in endometriosis? Endometriosis is hormone mediated. Then why do you think they have so much of problems? There is neurovascular condition which causes this chronic pelvic pain, and of course, infertility and deterioration of life. The presence of endometrial tissue inside the estrogen and the chronic, and which is dependent on this inflammatory reaction, and then the pain derives from increased prostaglandin compression and infiltration of the adjacent nerve. So there's increased expression of nerve growth factor, increased density of nerve fibers, angiogenesis, which all contributors to this kind of pain. So endometriosis associated with pain, there is peritoneal fluid in these people, which have high level nerve growth factors to promote neurogenesis. The ratio of sympathetic and the sensory fibers significantly altered because of the endometriotic tissue. The nerve density is increased. The cytokines and prostaglandins produced by the mast cells and other inflammatory cells, they also are attracted to this ectopic endometrium with this inflammatory response. And the nerve fiber entrapment within the endometrial implants is another source of pain, and this causes cyclical pain, and there is entrapment with the sciatic, femoral and lumbosacral roots, and then the central sensitization. Another mechanism that promotes endometriosis and pain is highly sensitive to subsequent pain stimuli because of endometriosis induced neuroplastic changes in the descending pathways. So whenever there is pain, what do? We give NSAIDs, we give hormone treatment, and then we offer surgery. The individuals usually prefer to take pain. I mean, medical therapy is their
preference. So options is hormonal treatment, combined hormonal contraception, progestogen, then GnRH agonists, GnRH antagonists, and aromatase inhibitors are the medical therapies which we give. And this is, of course, about the infertility, which I'll be not going to. The surgical management of these patients with chronic pelvic pain is endometriosis, when symptomatic, can cause dysmenorrhea, dyspareunia, and deep dyspareunia, dyschexia, dysuria, and chronic pelvic pain. So it is important to note the gold standard in diagnosing this endometriosis, and surgical excision really helps in some cases. So consider surgery when and avoid surgery when. Consider surgery when pain is refractory to medical therapy, declines medical therapy or contraindications to medical therapy, and pathology requiring tissue diagnosis, of course, and there's malignancy, and when there is bowel involvement. Avoid surgery when there is not much of chronic pelvic pain and postmenopausal women, and with women with previous multiple surgeries. So drug therapy relieves inflammation, and maybe if the corrective surgery is necessary, we have to do. Endometriomas, rectovaginal, and uterosacral lesions always require surgery, and an abnormal anatomy and adhesions always need surgery. So what is the evidence? If you look at the evidence, what should we do for this pain? Ablation of these nodules, yes, there is some evidence. There is no evidence for Luna, because Luna by itself has no effect on dysmenorrhea. There is some evidence regarding the presacral neurectomy. Of course, post-operative hormonal therapy does not produce a significant reduction, but at least decreases the recurrence or prevents the recurrence for some time. LNG-IUGS, yes, it has known to decrease the pain significantly of recurrent endometriotic lesions when there was a 1-year follow-up. So surgery, we are left with, when we have to do surgery, then we have to have a proper equipment, a proper setup, that is 3D or a camera set, and of course one has to know the anatomy. So the types, that is depending upon the patient's desire and location and proper instrumentation, skill of the surgeon, whatever is the type of the disease, so that depends and the surgeon's decision to take up for surgery. So if there is an ovarian endometrioma, what do? We do endometrioma drainage and excision of the wall, ablation we do, or cyst wall, or sclerotherapy, cyst wall removal or sclerotherapy we do. So whenever they have pain and when it is associated with infertility, most of them, and there is about stage 3 endometriosis, that is basically because of these deep infiltrating endometriosis. There is nerve entrapment. So you can see that the bowel is adherent there. There are some amount of bowel lesions, so that has to be separated. It may not be always the classical way of entering. That is, ureteric dissection may not always be necessary. Depending upon the severity, the age of the patient, the fertility, and the conservative management, we need to go ahead and do the kind of surgery. In this particular case, we did aspiration, and then we did the separation of the ovary, and we ureteric involvement was not there. So what we did was we did a cystectomy, and after the cystectomy, the cyst was sutured. So you can see that cystectomy is being done, and then the ovarian tissue is sutured. But that deep infiltrating endometriosis, this has to be separated, and all that fibrotic tissue you can see, that has to be removed. Only when you remove all this fibrotic tissue, the complete treatment is done. And then if there is infertility, then you have to ask the patient to conceive immediately, because in this particular case, you can see both the tubes are patent. This is stage 4 endometriosis, and this was a very bad case when this patient came with excruciating pain, and when we did a scan, we found a large cyst, and then when we went in, it was recurrent endometriosis. Because of her pain, we had to do the procedure. We did do a surgery in the past, but after that she didn't conceive. She did not come for follow-up, but later at this stage when she came, we had to do a proper aspiration of the cyst, and then the adhesiolysis, because you can see it is adherent to the anterior abdominal wall. Since there is distortion of anatomy, you have to go stepwise. Whatever is in front, layer by layer, you'll have to go. First, release the omentum, then do assist aspiration before you do a cystectomy. Identify the anatomy, whatever the landmarks you'll have to see, the ureter and the intestines, and then go ahead with the surgery. In this particular case, we left one ovary because this other ovary was completely gone. We had taken consent, and then we had also told her that you have to go in for IVF. So we did do a proper excision of this cyst, which was partially infected also. So once we finished the excision of the cyst, then with the other ovary looked okay. Then we did pooled a cycle IVF for her, and this patient conceived, and she took home a girl baby. So sometimes it is really challenging. See, you can see the bowel, which is badly adherent. And at places, now the energy source, you may ask me, whenever you're sure that you can do a good dissection, the harmonic, one can go ahead and do the harmonic dissection. But if you're not sure about the adhesions, or you're very close to the bowel, then it is better to do with the scissors. So you can see that now, after doing all this clearing, then I had to go to the lateral pelvic wall, separate the bowel, and then identify the ureter. And once the ureter is identified, then you know that the ureter is safe and there is no ureteric stricture, and then go ahead with bilateral ureteric dissection. And then the bowel separation was done. The other side, the ovary was retained. And then we completed the surgery, and post-op, we put her on 1 dose GnRH, and then did IVF for her. So the stage 1 and 2 endometriosis, best surgical approach is superficial endometriosis, controversial. Laser, of course, when there is pain and you see lesions, you have to remove. Uterosacral ablation to disrupt, it has not much of evidence. Presacral nervectomy has 87% efficacy, but the problem is there can be constipation and bladder and urinary symptoms. So this is the picture of presacral neurectomy. You can see the nerve here, hypogastric nerve here, which was separated. You have to at least remove 2 centimeters of the hypogastric nerve to get good results. So my video was not working properly, so I took pictures and it had a little bleeding. But here I can show you the identification which I of this nerve, and then the nerve excision is done. See, about 2 centimeters of the nerve excision is done. Here you can see the nerve clearly with the close-up there. So laser, of course, laser ablation of the nodules is being done. Excision or peritonectomy is ideal when there is pain. But when there is deep infiltrating endometriosis and there was large myoma, especially if it is adolescent, unmarried girl, then the big challenge is to relieve her from the pain and then to relieve her from the disease for some time. In this particular case, you can see that there is deep infiltrating endometriosis. This patient came from US and she was really in pain, and then we had to, initially I tried medical therapy, but when there is so much of problems, no medical therapy will work. So we had to do a surgical therapy. And of course, it was a conservative surgery. Initially, whatever bowel is adherent, all that was removed. Of course, we inject vasopressin. So you can go from the lateral pelvic wall also to identify the ureter. But before you can reach the plane, see, most of this time when there is adhesion like this, and when the identification of the planes become a challenge, so that time you have to go to stepwise. And first thing is, you suspend the uterus. I've suspended the uterus here, and then you separate the posterior ovary and the adhesion there. And then on the other side, we could see the fibroid. So the fibroid was removed, and then the complete surgery was done. And of course, now she's completely relieved with pain and she's on medical therapy now. So extension to the parametrium, when there is a culprit is the deep infiltrating endometriosis. Posteriorly, most of the time, it is badly adherent to the colon. And of course, extension to the ureters, where you'll have to separate the ureter. So exposure, traction, counter traction, meticulous hemostasis, judicious use of proper instruments and irrigation, and of course, a well-trained surgeon. So the so sure resection is survey, then ovarian mobilization, suspension of ovaries, uterolysis, rectovaginal septum entry and entry into the pararectal space and resection of definite pathology. This is one deep infiltrating endometriosis where we did a retroperitoneal dissection, and you can see that it is badly adherent there. So I can just show you. First, we dissected the ureter. Here I have done the posterior approach of ureteric dissection. So you can do posterior or lateral approach, whichever is feasible. Depending upon the amount of adhesions, I decide whether I'll do posterior approach or lateral approach for ureteric dissection. And of course, the bowel has to be resected, and depending upon the number of lesions there, whether you're going to do a shaving or discoid or end-to-end anastomosis has to be decided. So that a type of DIE etiology is not clear, suggested to originate from metaplasia of Mullerian remnants in the retrovaginal septum. So OC pills is tried with level B evidence, and this is adenomyotic lesions. Sometimes the adenomyotic lesions are also very painful. In this particular case, she had adenomyosis, and you can see those blue adenomyotic lesions, which has a lot of pain. And this lady also came from US, and then we did the surgery for her and put her on medical therapy and sent her there, though there is no evidence, at least to suppress the disease for some time till she went to US. And US, she has undergone an IVF and she has conceived also. So you can see that the adenomyotic lesion which is there, and I will show you the separation because there are so many videos and I have to fast forward. See how much of adhesion is there. And this is completely separated picture. So ureteric dissection, of course, when there is deep intimacy, here the bowel is adherent. This is the suspension. There, I didn't show you the suspension. Here, you take a stitch and then pull it with the cobbler's needle to anterior abdominal wall. And then you can suspend. And once you suspend the uterus and the ovaries, it becomes easy. See, you can see the ureter so well. So then you start ureteric dissection. So that's when things become easy and you don't go wrong in your anatomy. So as a beginner, it is always better to learn all this by a trained gynecologist. Go to training centers which are doing this. And mind you, please do not call any surgeon because they are not well trained in this. Take your training from a gynecologist who is well versed with these techniques. So adhesions, size, complication, dissection, all are the factors which you have to keep in mind.
Sorry to interrupt you, Vidya. I think you're running short of time. Are you done?
Okay. I'm finished. I finished. So posterior approach, lateral approach, I told you, this is one of the hysterectomies. I will just run through this video and then you can see that posterior. This is how you have to go separate. This is my last video and then I'll conclude. And see, this is how you do the lateral approach I've done. The classical teaching is posterior approach, but when there is adhesions in the posterior approach, always go in the lateral approach and then you ligate the uterine artery at its origin, identify the ureters and do the hysterectomy. So there are alternative therapies, acupuncture, transcutaneous electrical nerve stimulation. This has been done and some studies suggest that TENS machines are very effective and in reducing the pain. Heat pads are also used. These will relax the muscles and stress relief. Of course, chronic inflammation, impact of hormones and yoga and meditation. So multimodal therapy is hormonal therapy, surgery whenever necessary, pain management, physiotherapy, osteopathy, nutrition, psychotherapy, completely a holistic approach you should give for these patients with the endometriosis. So if it is young, give the option of egg preservation and preoperative medical suppression to avoid removal of functional cysts can be done, and postoperative hormonal suppression to decrease recurrence if at all. Thank you very much for your kind attention.
Thank you, Dr. Vidya. I know it's as complex as that. The topic itself would be to treat somebody with pain and endometriosis. Shall we move on to the next one?
Yes, ma'am. Thank you so much.
Yes, we have role of GnRH in infertility.
Yeah.
And I think because
I
Dr.
think,
Anu Chawla is not
that is
available,
that is
Dr.
not
Ramani will be
there.
handling this topic for us.
Yes,
No,
yes,
no.
that's right. Dr. Anu Chawla is not there, so Madam Ramani Devi.
That's
will
what.
take it.
So Dr. Ramani
But
will
I am
take over.
not talking GNRH because she will be doing it tomorrow. Yeah, I want to share my screen. Please take off the intro slides.
Yeah.
Take off.
Yes.
Take that off.
Dr. Suhas.
All of us know that Ramani is a doyen in infertility.
Dr. Suhas.
And I mean endometriosis. So she'll be dealing with endometriosis. And what is your topic for today?
Yeah, today I'm going to talk about endometriosis fertility index.
Fertility. Yes. Okay.
Okay, can you see my screen? Yeah.
Yes.
So, though I am an odd man out in this surgical topic, I think endometriosis fertility index and its applications are very, very important. So the plan of my talk will be introduction, stages of endometriosis, what is endometriosis fertility index, what is the clinical application, what is modified EFI, and what is its relationship between EFI and ART, and conclusion. So this is all the intro slides. 1 in 10 women, they have of reproductive age group, they have endometriosis, and among the infertile population, 30 to 50% will have endometriosis, and 25 to, and it is vice versa when you consider endometriosis and infertility. So the prevalence in India is almost 26 million that was being discussed by Dr. Das Mahapatra in 2007, but it has increased to more than 50 million Indian women are supposed to suffer, according to the Kolkata Endometriosis Society of India survey. So 5% of the women, girls below 18, they do complain of dysmenorrhea or affected by endometriosis. So these are all the various phenotypes of endometriosis: ovarian, deep infiltrative, peritoneal, and adenomyosis. So the symptoms, I am very fond of saying the 70s, added to the 70s, depression and fatigability are there. So the incidence, this slide has been shown by Dr. Lakshmi Srikande, etc. That was in our study that was published in 2016. We had an incidence of 34.2% of the infertility population had endometriosis, but it was slightly higher in the Dr. Vineet Mishra study. Why is there subfertility in endometriosis? Again, tomorrow we have an extensive topic on this by Dr. Bharti Dore Patel. It may be straight from the pituitary to the like altered pituitary ovarian axis, then fertilization problems, ovulation, anovulation, or sometimes impaired folliculogenesis, luteal phase defect. Then again, the pre-implantation embryo may be poor quality. There is abnormal implantation. And then again, we have a lot of pregnancy complications, even if the woman conceives. So there are various staging systems so far discussed. And according to Sampson Acosta et al. Was the earliest one, followed by American Fertility Society classification. Then came the revised AFS scoring, and then Enzian classification. But none of the staging system, they do not predict what is the fertility outcome, whether it is a stage 1 or stage 2 or stage 3 or stage 4, what is the fertility outcome? And it is only the Enzian classification where they have included the deep infiltrative endometriosis. So this is a picture of the revised ASRM classification, and we see stage 1 is minimal, where there is less than 5 points. About 6 to 15, it is stage 2 mild. Stage 3 is 16 to 40 points, and stage 4 are severe endometriosis, where they have 40 points. And these points are all given in the revised ASRM classification protocol, and then we can do a laparoscopy and then put the score and then come to a conclusion. But then what is the drawback of the revised AFS classification? It is though it is the most frequently used classification for staging of endometriosis, it cannot predict the outcome of clinical outcome of treatment, especially the pregnancy rate in infertile women. And then again, it cannot correlate the symptoms and the staging. For example, stage 1 patient may have very severe symptoms, but stage 4, they may be asymptomatic. Again, extragenital endometriosis and adenomyosis are not included. This is the Enzian classification, what was already shown by Dr. Narendra Malhotra sir. Now, coming to endometriosis fertility index is a first validated scoring system that is predictive of non-ART pregnancy following evaluation. The patient should have functional gametes.
Again, it is saying not allowed.
Then pregnancy rates decrease significantly with decreased ovarian reserve, which is especially a problem in older patients. following cystectomy, AMH level also decreases. Again, endometriosis fertility index, it is reflected upon that and decreases over time if pregnancy does not happen in the first year or 1 or 2 years following surgery. So the patient management algorithms using this information to assist deciding whether to continue non-ART versus ART attempts at conceptions are presented. So it provides a comprehensive fertility treatment plan can be created. So the main idea of endometriosis fertility index is based upon the scoring system, we have come to a conclusion whether this patient can be put on for a non-ART conception or whether she has to be straight away shifted to ART. See how to predict infertility among endometriosis patients. We have 3 important parts in the EFI scoring system. That is history. Next comes the staging of endometriosis. Third one is finding at the end of the laparoscopy. So this scoring system, main thing is it can predict the future fertility. Then this is again a comprehensive statistic and analysis, how they came to it. It was Adamson's who in 2010, they have collected a lot of patients who have undergone surgery, laparoscopic surgery, and they were planning for pregnancy. So they had collected this, and based upon the predictions and based upon the history and the finding, they were able to come to a conclusion what was the score and whether they are eligible to be shifted to a non-ART or ART conception. So that as time goes upon, if we add up more and more parameters, we can be more predictive. So this is the first form which shows the least functional score at the conclusion of the surgery. This here the tubes, the right and the left side, each thing are scored based on the tubes, fimbria, and the ovary, and each point, whether if the tube is normal, it is given 4 points, and that if there is absent or totally a non-functional tube, it is given 0 point. Similarly, the fimbria, healthy fimbria 4 and absent fimbria, it is 0. So ovary, if it is healthy, normal ovaries, it is 4, and if the ovaries are totally absent or if there is severe dysfunction, the score varies, and ultimately we put the least score on the left side and the least score on the right side, and the least functional score is obtained by adding it. So these are all some of the pictures. Like first you see a ovary that is normal, but it has only slight few spots. Then the second one is it has a large endometrioma, but still there is quite a good amount of ovary that is remaining. Again, in the tube, there are few spots, and in the fimbria, there is totally, though it is patent, there is much of damage to the fimbria. Again, it is these are some of the pictures to show that the ovarian volume at the end of the surgery is quite low, and here both the tubes and the fimbria are totally non-functional. So again, based on this history, depending upon the age, if she is less than 35 or 36 to 39 or more than 40, the scoring is 2, 1, and 0. And years of infertility, whether it is less than 3 or more than 3, it is 2 or 0. And the prior pregnancy, even if it is an abortion, it gives a 0.1 score. So the total historical score is being added here. And again, the surgical score. At the end of the surgery, we calculate the least functional score. If the score is high, it is given 3 points. And again, we have to, based on the AFS endometriosis scoring from the laparoscopy, we can, if it is less than 16, it is 1, or if it is more than 16, it is 0. And total AFS, this is endometriosis score. And finally, ultimately, each point is, each organ is given one certain scores, and finally we add it. And if it is less than 71, there is 1 point. So ultimately, you add the historical plus surgery, you get the endometriosis fertility score. So this is what, it's a 10-point score, where as the score value increases, the chances of conceptions are going to be very good. And if the score is less than 3, practically the chances for conception, spontaneous conception, is going to be bad. So here, out of the 10 points, the 5 points are based on history, duration of fertility, and prior pregnancy. And then 2 points are given based on the revised ASRM scoring. And 3 out of the 10 points are based upon the end of the surgical qualitative visual assessment by the surgeon of the adnexial function, or otherwise it is the least functional score. So here I have put up one patient on a laparoscopy where the history says that she has 2 normal tubes. Okay, the ovaries here, you have endometriotic spot areas over the peritoneum here, and then there is, you have the endometrioma. So once when you can put the scoring. So this is the histoscopic view where this particular patient was found to have a septum also, and so the septal dissection was done here. So if you put in the score, the least function score on the left side is 3 and the right side is 3, and total LFS score is 6. So if the LFS score here is, if it comes to 2, that is 2 points, and endometriosis fertility score is 1, and the total score is 1. So put together, she will have, based on the history, 4 scores, based on the surgery, 4 scores, and EFI score is totally 8. So that means her chances of getting pregnant spontaneously is quite high. So this is the ultimate score, and where she was found to have a higher score. And I am happy to say this patient has conceived. So this is a second patient where she has got a large endometrioma as well as some dense uterine additions in the posterior wall. So after that, at the end of the surgery, her least functional score was 4. And when you go for through the historical and the surgical score, ultimately the endometriosis fertility score is found to be 6. So the option we can give her is, depending upon the AMH, male factor and the tubal factor, she can be pushed either directly to ART, or if everything is okay, maybe she can be given a trial of 2 or 3 cycles of IUI. So this is a third patient where she had adenomyosis along with endometriosis, and you can see the adenomyotic bulge in through the histoscopy. And then see, this is the dense addition, and her EFI score was like the least function score was only 2, and the endometriosis fertility score was like based on the history, it is 3, on surgery 0, and total EFI score was 3 only. So that means she is a candidate who should be straight away pushed to ART. So now the question is, how long you can wait after surgery? Because there is always a time limit. So according to various authors, Cook and Adamson or Dominic and so many other people, some are of the concern that we can shift to ART beyond 1 year, or a few of the authors are of the opinion that we can even wait for 2 years. But ultimately, the guidelines are you have to individualize the patient. If the EFI score is on the lower side, shift to ART as early as possible. So this was again, this was a study which was published in 2011 to 2012, 133 patients. After surgery, 55 of the 133 patients achieved pregnancy without ART, and they studied that the fact probably all these patients fell in the EFI group of higher than 6. So there was again another study to show unfavorable EFIs, you shift to ART earlier, and beyond 5 EFI, we can wait for a period of, they can attempt for a period of 24 months. But whatever it is, depending upon the age of the patient, we need to wait. If the age is on the higher side, maybe the waiting period for spontaneous conception is going to get reduced. It may be less than 2 years, or if it is a young patient, maybe we can wait for some more time. So this is the estimated fecundity rate. At the end of 3 years, maybe the fecundity starts coming up. And if the EFI score is high, the fecundity, maximum fecundity occurs at the end of the year 1. So again, what should be the treatment level? When the monthly fecundity is more than 3, attempt non-ART conception. 2 to 3, probably attempt non-ART conception. Consider the role of IVF. And 1 to 3, 2% monthly fecundity rate, we have to go for a probable IVF, and less than 1, it is definitely IVF. So based on this, and the number of patients, see 801 patients Adamson has tried, and he has classified. You can just apply this, apply the EFS score, and at the end of end of 1 year, what should be your treatment plan? 4 means ART, 3 means probable ART, 2 means we can wait, and 1 means non-ART conception. So this is based upon the age. Lesser the age, we can go for a waiting period can be higher. Then there was again another study, according to the EFI score in non-ART conception. So this was a study which clearly shows higher the EFI score, higher will be the conception rate. So this was again another study which shows there is only 10% conception spontaneously if the score is 0 to 2, but it comes to 69% when the EFI score is 9 to 10%. So this says that EFI score has got a good performance in predicting the non-ART conception. So this was again another study to show the same thing. And now we have, do we need to do laparoscopy for every patient? See, then again, it has been modified. EFI has come out because in estimated type A, it is only a non-surgical clinical imaging. In type B, we include only diagnostic laparoscopy. In type final EFI, we get by type A and type B, intraoperative, and type C is at the end of the surgery. Now, this surgical modality, because we have only 3 points for EFI for surgical modality. So it can be replaced by a non-invasive way. We can use FOGSI for tubal patency assessment, and ultrasound and all the adherence of the ovaries and the DIE can be picked up by very nicely by properly done ultrasound study. See here, left ovary is adherent, right ovary has got 2 endometriotic thing, and the sliding line is absent. So this is the same patient. The laparoscopy shows the same findings what we have picked up in the ultrasound, and this is at the end of the surgery. So by supporting only with the ultrasound findings, we can skip the laparoscopy. For example, if in the modified EFE is found to have a higher EFI index, maybe without even laparoscopy, we can go for ovulation induction with IUI. But on the other hand, if the EFI scoring is going to be less than 4, maybe the patient may not even need a laparoscopy. We can bypass that, and this score modified EFI can be used as a triage so that we can straight away go for ART. And these are all some of the other indications where we need to go for straight ART. Then whether endometriosis fertility index is useful in predicting ART pregnancy also. Yes, it can also predict the ART pregnancy also. So here, stage 1 and stage 2, always they have a better outcome than stage 3 and stage 4. And here again, we can see that non-IVF ET group, they have a lower pregnancy rate when compared to the ART group. So this score again says that we can have a better IVF outcomes can be predicted by EFI scoring. So this is again a study where they have tried with few patients and their ART live births were compared. Even with the lower scores, the percentage of ART outcome when compared to the non-ART pregnancy was found to be high. So the take-home message is Adamson provides a rational and systemic approach to evaluation and treatment of endometriosis-related infertility. Treatment consideration should include availability to time to conceive, ovarian reserve, and the possibility to conceive by non-ART means. Women with decreased ovarian reserve should consider ART. Male and uterine factors should be considered. And then EFI predicts the pregnancy rates over a period of 3 years, providing a simple visual graph for educating both the physician and the patient. So infertility patients in whom ART is a potential treatment option should be shifted to ART by the age of 36 years. I feel that is even too high for our setup. It should be better they are shifted at 32 years. So infertility patients should attempt pregnancy by non-ART means for 2 to 3 years in young patients, as it has been elucidated by the EFI. EFI score can be used to create a non-ART treatment levels and prognosis for the non-ART conception. Thank you.
Thank you, Dr. Ramani, for that elaborate talk. And I think we should put this into practice every time we operate on an endometriosis.
Yes.
Especially those with infertility. It will help us to really counsel them on what would they be expecting out of what we would treat them. Thank you. I think with that we come to the end of
fantastic talk, Ramani. Enjoyed the talk.
And we move on to
thank
the
you,
third
thank
one.
you.
Yeah,
I thank you, organizers.
Yes. Thank you so much, Dr. Ramani, for that excellent talk, and Dr. Chitra for wonderfully chairing the session and wonderful compelling comments as well. So now we move on to the next session, that is the panel discussion. And for this, may I invite the expert, Dr. Uday Chanavala, who is the immediate past chair of ICOG and serves as the vice president of FOGSI in the year 2015 and the chairperson for Medical Disorders Committee in the year 2008. Welcome, sir. I invite the two moderators, Dr. Parul Kotradawala and Dr. Asha Rao. Dr. Parul Kotradawala is a senior obstetrician from Ahmedabad, the vice chairperson of ICOG, and sir has got the special interest in the field of endometriosis, and he was the chairperson of FOGSI Adolescent Health Committee and was the recipient of Merudara Sutiya Award. Welcome, sir. And I welcome Dr. Asha Rao, who is the convener of this program and at present the chairperson for Endometriosis Committee, FOGSI. Madam is the director of Rao Hospital Care, Coimbatore, and she is, all of us know her as successful chairperson, organizing chairperson for the South Zone Year FOGSI 2019. So the forum is all yours, Dr. Asha and Dr. Parul Kotradawala.
Hello. Good evening.
Thank you.
Yeah.
Dr. Sneha for those kind words. Dr. Parul, shall I just share my screen?
Please. There has been a feeler from the chairperson, Dr. Lakshmi, that you wind up quickly because we are already quite late. Okay.
Quickly, we just in 45-50 minutes. I mean, we are really late by 45 minutes. So it's just a request. Yeah.
See, we are the last flight of the day.
Yes.
So all late evening flights are delayed, isn't it?
Yes.
Yeah. Okay, so I welcome Dr. Uday, a close friend of mine, and
sorry to interrupt, Parul, sir, just one sec. Nilima, can we unmute all the panelists? All of them are muted. So please unmute everybody.
And would you, Dr. Sneha, introduce all the panelists, or it is our privilege?
It's your privilege. We can just welcome them, I think, because we are late. Thank you, sir.
Yeah. So we have, how many? Just 4? No, there were many more listed.
Oh.
Few names are missing.
No, they're all there. Yes, they're all there.
Mala Raj, Kavita Gautam,
Yeah.
missing.
So we welcome our panelists.
Okay.
7 are there.
Yeah.
So Asha, you can carry on.
Thank you. Thank you. So, yeah, it is such a privilege to be co-moderating with Dr. Parul Kotradawala, eminent endoscopic surgeon, and our expert of the day is Dr. Uday Tanawala, the past chairperson of ICOG, and we have eminent panelists, Dr. Anita Singh, Dr. Vidya Tobi, Malaraj, Dr. Manju Khimani, Manjula Anagani, Subhash Malya, and Kavita Gautam. Each one is a shining star in their own field and do not need introduction. And today's topic is adenomyosis, challenges in management. As all of us know, adenomyosis is the disease which causes associated with heavy menstrual bleeding in 40 to 60% of patients, dysmenorrhea in 50%, and the disease which was supposed to be historically diagnosed by histopathology at hysterectomy and was said to be a disease of Paris women, today is more often being diagnosed in the setting of infertility and is being blamed sometimes for recurrent implantation failure and for reproductive dysfunction. And there is a tremendous change in the trend. It is seen in almost 30% of young women and infertile women, and also diagnosed in 22% of infertile women less than 40 years undergoing ART. This fact is very important because those years when they were 40 years and fertile, we could very easily offer them one-stop treatment that was hysterectomy. We can't do this anymore because they're young and they come to you seeking pregnancy. So that's why it's very important to save the integrity of the uterus. See that, because surgery was being practiced almost from 1952. But later we realized that surgery can sometimes, occasionally, there can be a chance of rupture uterus. So it's very important to preserve the integrity of the uterus and be conservative to save their future fertility. And this is a disease of the junctional zone. All of us know about that. And this is a beautiful depiction by Monroe et al. There is myohypoplasia and there is local hyperestrogenism, increased peristalsis, tissue injury and repair. The factors which are favorable to implantation are decreased, and factors which are adverse to implantation are increased. And there is myohyperplasia. This is maybe classified as focal or diffuse. Sometimes it can also be only a junctional zone thickness. And junctional zone is a very, very important area of the uterus. And according to Pivers et al., whenever the junctional zone is more than 10 millimeter, the implantation rates drop down. When it's less than 10 millimeter, the pregnancy rates could be almost 45% per transfer, while the rates as low as 16% and 5% were observed when the junctional zone thickness was 10 to 12 millimeter or more than 12 millimeter. So evaluation of junctional zone thickness is the best negative predictor for implantation failure. And adenomyosis can also cause changes in the muscle layer, which can vary from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis. And this can expect to change the plasticity and tonus of the uterus. And this seems to be playing a major role in causing menorrhagia, dysmenorrhea, preterm delivery, etc. And this again causes altered contractility of the myometrium, impaired gamete transport, leads to infertility, poor implantation, poor placentation, miscarriage, preterm labor, IUGR, and all these are the side effects of adenomyosis. Decreased pregnancy rate, 23% versus 44% was seen in adenomyotic versus non-adenomyotic group in a study by Talluri and Tremelin. Then they gave them ultra-long down regulation, which seemed to improve the pregnancy rates. And this was an early study in 2011. And today we have seen so many other papers which talk about causing uterine volume reduction and suppression of adenomyosis in improving pregnancy rates and improving the pregnancy outcome compared to medical management. Adenomyosis is also one of the important groups of palm coin group of diseases causing menorrhagia. So menorrhagia and infertility are the two hallmarks, and management is a lifelong management. It depends on woman's age, reproductive status, clinical symptoms, and type of adenomyosis, focal, diffuse. So how can we manage these patients when they come to your doorstep? We have 2 to 3 cases of infertility, a couple of cases depicting the need for surgery, and then we also have a case for pain management. So the first is Mrs. S, 34 years, infertility of 5 years with severe dysmenorrhea. She has irregular periods, history of laparoscopy for grade 4 endometriosis 3 years back, failed IVF 6 months back. Her AMH is 2.3, normal male factor, very keen on pregnancy. How will you proceed, Dr. Malaraj?
This lady, I think, a case of deep infiltrating endometriosis, grade 4, 3 years back. By the current scenario, we don't know how exactly it is. It is still grade 4 endometriosis or not, because she still seems to be having so much of pain. And her AMH is 2.3. It is apparently good. So what I feel is like in this case, better not to wait any further.
And she has a failed IVF already 6 months back.
6 months back. Yeah, that's what. And but her surgery was done 3 years ago.
Yes, it was a laparoscopy elsewhere.
Yeah, so maybe we can, if the pain is very severe, then ideally speaking, in this case, I will evaluate.
What do you, yeah, okay, sure.
Evaluate her further and see whether she would benefit from another surgery, because unless and until.
So how do you rate this ultrasound? DIE and anything else? Do you see, Dr. Kavita?
Yeah, we can see a little bit of rectal involvement also. There is so much of adhesions and probably looks like a rectal nodule. So that is the reason she's got so much of dysmenorrhea. So she would definitely benefit from a repeat surgery wherein you have to do a thorough clearance of all these lesions. So we have to release these nodules and get the uterus mobile so that ultimately she'll.
So you think, no, let us have short discussions. So you think that she's a case of grade 4 endometriosis with rectal adhesion, right? With the posterior nodule. Any opinions from Dr. Kimani? Manju Kimani, are you here?
Yeah, I'm here, but, I would like to know in the first IVF, how many oocytes were retrieved? What was the grade of embryo? Does she have any preserved, embryos? What grade they are, before I, say she needs surgery?
True, but would anybody think of a posterior wall adenomyosis by the picture here?
Ma'am, it looks like posterior wall adenomyosis diffuse with poor junctional zone is not very clear. The endometrium is not at all clear. And I would suggest that if the patient's priority is to...
This is her, So now you should ask for a good ultrasound and ask for a 3D.
Yes.
That's very important. And this is a 3D picture. Can you see it here?
Yes. Yes.
So how will you manage this case now, Dr. Manjula?
Definitely, I would go like Nala said, second look laparoscopy is the way to go. First to release the adhesions so that the entrapment of ovaries is removed so that the quality of eggs also will improve. Plus the posterior adenomyomectomy is going to go a long way in decreasing the implantation failures. So in this case, adhesiolysis, DIE, retrovaginal nodule excision, and the posterior decompressing the tissue. That is what I would say, to decrease the amount of posterior adenomyoma is what I would go in for because of failure.
Yeah, so to summarize, her good points are that her AMH is decent, male factor is normal,
yes,
and there is a slight impingement of the cavity. So will anybody think of a medical adenomyomectomy rather than a surgical adenomyomectomy?
When anybody wants to become pregnant, there's no role of medical management.
No. I differ, Dr. Manjula, from you.
You should not be waiting for 6 to 8 months, Dr. Manju Kimani, because if you are giving a medical management for 6 to 8 months, that for a lady who wants to conceive,
Let me just finish.
Yes.
Let me just finish.
Yes, and if you do a surgical management for this size adenomyosis, you should definitely wait for 5 to 6 months. Because if she conceives twins, her chance of rupture are very high.
Asha, I would like to add 2 things here, So if you are doing surgery, after surgery, minimum they say 6 to 12 months, and after surgery, you should see whether the blood flow has come back to no. If blood flow has not come back, then chance of rupture are high, one thing. Secondly, in this patient, why not, first retrieve the egg, give her GnRH analog, along with that, give her letrozole, and both will reduce the uterine volume. And then give her a chance of transfer rather than straightway going for surgery. That's my opinion.
Fantastic. That's exactly what I said by medical adenomyomectomy versus surgical adenomyomectomy. Because today we have any number of papers which have said that pre-transfer IVF, GnRH for 3 to 6 cycles can optimize the ART outcome. GnRH analogs decrease the expression of aromatase cytochrome B450 in the utopic endometrium of women with adenomyosis. They decrease the expression of nitric oxide synthesis. So they act at the molecular level in the utopic endometrium. And also, after 2 to 6 months of GnRH analog, the mean uterine volume reduction can be almost from 180 ml to 86%, which is fantastic. What more can you achieve by surgical, by giving a scar? It's only a tip of the iceberg that you are removing because the basic disease may remain. And if she fails within another 4 to 6 months, she is going to recur also. Plus, if she conceives very early, she can have a very high chance of uterine scar rupture. What will be the incidence of scar rupture? Shall I ask Dr. Vidya Tobi? In
one point here,
non-adenomyotic women versus adenomyotic women.
Madam, just one
point. You have Dr. Vidya here?
Madam Asha, ma'am, just one point in favor of surgery.
Yeah, just let us clarify this one point with Dr. Vidya Tobi, the chance of scar rupture. Is she here?
She's not.
No.
Asha, can I answer this?
Okay, yeah, come on, Dr. Mala, you were saying something?
Yeah, ma'am. See, in this particular case, already all these have been done earlier and she has failed. So now there
I'm sorry. She only had a laparoscopy for endometriosis. Perhaps they would have cleared some adhesions. They might have drained a cyst. She had no adenomyomectomy earlier.
True, ma'am.
She has failed in.
No, but it was grade 4.
Diagnosed now.
Yeah, that is fine.
Yeah, grade 4 endometriosis with posterior wall adenomyosis. The best is to have a medical suppression. You do not gain anything by going and releasing some adhesions. The reason for not conceiving is adenomyosis, which is impinging a bit on the endometrium. And if you can achieve volume reduction like this, 180 ml to 80 ml, that means 60% volume reduction, which is fantastic.
Madam,
and once again, these are the papers by Holmes et al. Adenomyosis has no adverse effects on IVF FOGSI outcome in women with endometriosis treated with long-term pituitary downregulation before embryo transfer, before IVF, which is a very important statement as long back in 2010 and in last 12 years. So many more papers have come, and we have a study of almost 80 patients where we have had 45% implantation rate and 70% live birth rate in patients with adenomyosis just with medical management. The idea is when the medicines are effective, there is no need to go and operate on them with surgery. One more paper from Stenakova and Chemelin. The rate of euploid miscarriage. Dr. Kimani was saying you must check the quality of embryo. So they transferred euploid embryos and they found that, so all embryos being normal, the GnRH analog prior to ET boosted implantation, and it also improved the post-implantation pregnancy health. That is, the chances of preterm labor also came down. So these are the paper by Chemelin, Russell, Neo et al., Tulandi et al. So there are any number of papers. So the rate of euploid miscarriage also decreased after medical management. So you do not need to do a surgical management. This is the statement of the decade. Gone are the days when you could go and remove a small adenomyoma. Even this adenomyoma was 4 centimeters and responded so beautifully to medical management. We at Rao Hospital, this was done 4 years back. So those days we gave her a long GnRH because she had a lot of pain. She was suffering. We gave her a long GnRH analog. And after 3 months, we did the egg collection. And then we have done a frozen embryo transfer. And she's a happy mother of 3-year-old child now. We waited for 4 months, which is worth it compared to doing a surgery. And after surgery, anyway, again, you'll be giving her GnRH analog for further suppression because the disease removal is incomplete. Chance of recurrence are high. Scar healing does not happen for about 5 to 6 months. So all this we have achieved by giving her a medical management. So does anybody have, so today the lesson is that medical management can work very well and it can give in so many cases a volume reduction by almost about 50%, which is very impressive. Does anybody have opinions for gynecologist? Do we have Dr. Anita Singh here? Dr. Anita, Dr. Vidya Tobi? No. Dr. Kavita, what's your opinion regarding gynecologist?
I am here, Dr. Anita Singh.
Oh, Dr. Anita, ma'am, yeah. What's your opinion regarding gynecologist for volume reduction in adenomyosis?
Particularly for adenomyosis, I have not used gynecologist. I am using GnRH only.
Asha, we know that, this adenomyosis does not have any great role. It is okay for endometriosis. If you use gynecologist in adenomyosis, the women has quite a lot of bleeding issues. There'll be intermittent bleeding.
Yeah, you are very much right, Mala. It can give a, in patients who have completed their fertility, they have some pain because of adenomyosis. So again, the gynecologist seems to be very good for management of dysmenorrhea, dyspareunia, and chronic pelvic pain. But it is not as good as GnRH analog for controlling menorrhagia or for control of uterine volume. You are very much right. So gynecologist is good for pain relief, but not for uterine volume reduction.
Asha,
the only good point of gynecologist is that it maintains, yeah, sure.
Asha, can I add?
It can maintain estrogen levels and bone density loss is not there. Sure, sure.
So Asha, regarding
please.
Regarding gynecologist, I agree with you that it does not reduce volume. And gynecologist is known that it will cause, spotting this thing. So now, they're coming up that, first you give them GnRH analog, reduce the volume of the uterus, then you put them for the long term on the gynecologist and they will respond better. You have to choose your patient.
that is for gynec patients who are coming to you for pain.
Menorrhagia.
But here we are talking about uterine volume reduction, which is required urgently. So this is a paper by Matsushima et al. In 2018. They did a 16-week study of 3 groups, GnRH analog, low-dose estrogen, progesterone, and Dynogest. And after 16 weeks of therapy, the uterine volume came down from 307 cc to 177 cc. More than 15% volume reduction in GnRH group. Low-dose estrogen, progesterone, it remained almost same. And Dynogest group also, it remained almost same. So there is no role for Dynogest in patients who are infertile and waiting for volume reduction. The best is GnRH analog. And what is the best stimulation protocol for this patient, Dr. Kavita? Do you want agonist, antagonist, ultra-long?
Ma'am, I don't think stimulation protocol differs here for adenomyosis. Since the AMH level is 2.3, I would suggest normal antagonist protocol. But for embryo transfer, probably I would prefer a downregulated frozen embryo transfer.
Yes, you are very much right. Since her AMH is good, you can give her any protocol. You can even give her a luteal agonist protocol, or you can give her a short protocol like antagonist. But this patient was insisting on pain relief. So this particular lady, we had to give her a GnRH depot. We waited for 3 months because she was suffering from pain. She said, no, I do not believe in you. Give me pain relief first. So we gave her a pain relief and then we did an egg collection. We had 5 oocytes, 3 embryos. And are you for FET or fresh transfer? Kavita.
For adenomyosis, I never prefer a fresh transfer. It is better to give a downregulated, little bit suppression and then go for transfer, because the posterior...
Yeah, I think today all of us agree with you that downregulated transfer is the best.
Ma'am, this case, ANTA protocol is much better, ma'am, in adenomyosis than agonist protocol. And
agreed, yeah. That's what we are following all today. I said this lady was done 4 years back, insisting on pain relief. So she was given a long protocol because she also had a good AMH. But today I would definitely vouch for short protocol, pick up the eggs, then give a suppression and then do an embryo transfer. Agree. Any role for LNG-IUS in these patients? Dr. Anita Singh, ma'am.
Any patient who is with infertility, there is no role of LNG-IUS, because that is going to be a very slow sort of treatment and the patient needs fertility. So LNG-IUS, I think it is no, complete no.
Yeah, but today, once again, there's a change in thought. In some patients with severe pain, where they want to wait, you can give a GnRH analog. Along with GnRH analog, you can give an intrauterine device. There is a very good action, causes deserialization of the endometrium and adenomyotic deposits. And there is a good relief of pain. And some patients with thick endometrium, we have seen sometimes they have endometrial hyperplasia also in this patient. Thick endometrium, polypoidal endometrium is associated with adenomyosis. And these patients respond very well to intrauterine device also. So some patients you give intrauterine device along with GnRH analog, wait for 3 months, and then you can do the embryo transfer. And there is a paper by Liang et al. In 2019, where they have shown that implantation rates went up to 32% from 22%. Clinical pregnancy rates also went up to 44% from 33%. In a combination of LNG-IUS with GnRH analog. So there is a change in trend. Intrauterine device can be used and they can do very well. So case 2 is a minimum 6. So summary of the story is today. So let me just summarize because we have short time. So summary of the story here is, in this infertile woman with dysmenorrhea, you can control her pain with GnRH analog. You can do any protocol according to her AMH. There is no need for surgical intervention because it takes much longer and chances of rupture are much more. So this type of patients with dysmenorrhea and infertility can be managed beautifully by GnRH analog. And now the next case is case 2. She is 26 years, history of dysmenorrhea, sharp shooting pain in the rectum, dysphagia during day 1 to day 4. She takes antispasmodics. Male factor is normal. And how will you manage, Dr. Kimani?
What is her ultrasound report? She has male factor is normal. What is her AMH? I would like to know the other parameters before I answer this,
Yeah, this is her ultrasound. She has, ovaries shows a small chocolate cyst, tiny. And ultrasound showed a 2.5 centimeter anterior adenomyosis. Sorry, posterior wall focal adenomyosis 2.6 into 1.9.
She's very young. She's hardly 26. Has she already tried, or she has tried and failed, and now she has come to as an infertility patient?
No, she has not tried.
No, she is married
A
since
short
1
duration
year.
of infertility. So how will you proceed? We'll make it a quick discussion. Mala, how will you proceed?
Ovarian stimulation, madam. Just we can give her a letter wall. Gonadotrophin injections, follicular tracking, IUI.
She said she had a lot of pain during sex also. She has dysphagia, etc. Dr. Manjula, any opinions? Dr.
First, if her pregnancy, she has not.
Dr. Parul, we have never disturbed you at all. Dr. Parul, what's your opinion?
No, I tried to say something in between, but
sorry, I think too many ladies.
It's going on so smoothly and fast that let us get it on. No issue.
So I think that Dr. Mara said 3 cycles you should be trying with the
Dr. Uday Tanawala, I think we have not disturbed him. We have allowed him to be quiet.
No, he has gone to attend an emergency. No, okay. He has gone to attend an emergency. He'll be back after some time.
Okay, fine.
So Asha, here
so right now has a small chocolate, 1.6
So to relieve her pain, the main thing is pain. She's not even going to have, she has dyspareunia, dysphagia, right? So why not to give her, 3 cycles of, GnRH analog, suppress her adenomyosis, and then stimulate her, and then allow her to conceive. This is what I personally feel I will do.
Yeah, but she's young and she's married for 2 years and trying only for 1 year. And her left ovary showed 1.4 centimeter dominant follicle in this cycle, this very cycle. So what we told her was, and she had a tiny chocolate cyst in the right side. We told her, okay, if you do not get pregnant, try a couple of cycles, maybe one IUI also. Maybe in future you may require a laparoscopy for, let us try conservative first. So this cycle we told her, your follicle is 1.4, come back after 2 days. It showed a 1.8 centimeter follicle after 2 days. We told her, go ahead and try fertile period because she is not very much interested in frequent sex. We said, no, fertile period has come and please try. And that very cycle, she conceived. And she had a low-lying placenta. She did very well. We said, okay, if you do not conceive next cycle, come for a tubal patency, blah, blah. She conceived in the same cycle and continued pregnancy very well. She had a low-lying placenta. And later she had a mobile head. She had to undergo a LSCS, but she has done very well with the term pregnancy. So this is a happy ending. Young patient with small adenomyosis, minimal endometriosis, good male factor. She tried, and maybe some other patient did not try. You can do a tubal patency, try ovarian stimulation, or try IUI, and many of them may conceive. If they do not conceive, then you can think of the next step. So how many?
We agree with you. 3 cycles of conservative followed by laparoscopy is the way we do for such cases.
So now we have she comes 11 months after childbirth with dysphagia, dysmenorrhea. What shall we do for her? It is a posterior wall adenomyosis 3 centimeter.
We can try
surgery. Now the baby is 11 months.
So we can try LNG-IUS first.
Done. Agreed, Manjula. Thank you so much. So we went in for LNG-IUS. Now after 3 years, she removed the LNG-IUS. She has conceived again. She is about 8 weeks pregnant now. Thank you all for your advice. Yeah, this is a third case. This is Mrs. X. She is 32 years, married for 5 years. She had 1 miscarriage earlier. Her ultrasound shows a diffuse adenomyosis, enlarged uterus. The uterine volume was, I think, around 344 cc, which is like a 12-week size uterus. And she has a diffuse adenomyosis of, you can see it here, 7.5 centimeter into 5 centimeter. Poor ovarian reserve. Her AMH is 1.26. AFC is 4+5. ANA applied negative. She had 1 miscarriage earlier and she wants a pregnancy now. She also has dysmenorrhea. What will you do? Dr. Kavita?
Ma'am, can I get the age of the patient?
32 years.
32.
She married 5 years, 1 miscarriage.
Probably I will suggest, to proceed with IVF rather than trying any other fertility management, because she's married for 5 years and looks like with a poor ovarian reserve. And with diffuse adenomyosis, the chances for natural conception is definitely reduced. So my suggestion would be an IVF.
No, diffuse adenomyosis will also lead to abortion.
Her type taking, yeah. So what do you do about getting her a live birth?
GnRH analog to reduce the uterine
Probably
size.
a GnRH analog down regulator for few cycles. Then probably look into stimulating her.
Thank you, Dr. Manjula. Any opinion, Manjula?
See, I think we are surgeons with 7.5 centimeter, definitely I would look at adenomyomectomy. 7.5 centimeter is quite big. So I would definitely.
Yeah, okay. Dr. Mala, any opinion? Dr. Anita, ma'am?
Surgery combined after surgery, of course, IVF, because diffuse adenomyosis with so much of volume and such a thick junctional zone, she will definitely have, even if she gets pregnant, it's going to, the missed abortion is going to happen again. So reduce the volume of the myometrium first. And then after that, you can give her GnRH, collect the embryos and then give her GnRH for endometrial receptivity and then transfer the embryos. So it's a—
Here we agree with Kavita that her AMH is low, 1.26. Any surgery, sometimes there can be interference of pelvic blood supply. So we went ahead and did an antagonist protocol and did an egg collection and vitrified the embryos. So we have vitrified the embryos now. And after that, do you want to do adenomyomectomy or medical management? This was my question. And a couple of you have said surgery. And I think Kavita said GnRH suppression.
Yeah. My suggestion would be suppression, because unless and until I do a first transfer and I see multiple failures with transfer, I don't jump into surgery directly.
I think you and me being ART people, we think alike, Mala. So you can give her GnRH, but we wanted a faster reduction. So we gave her a combination of GnRH analog plus aromatase. Because there are any number of studies which show that letrozole 2.5 milligram given over 8 to 12 weeks can give a very good volume reduction. The combined use of aromatase inhibitors and GnRH analog can give a volume reduction by 60%, as observed in the studies by Kimura et al. So there are papers to support this. Badavi, Kimura, they have had lovely papers. You can see there is a reduction in uterine volume and as well as reduction in size of the uterus and adenomyoma. So this lady came in the COVID year to us in 2020. Uterine volume initially was 344. We collected the embryos. Then we gave her 11.25 milligram along with letrozole 8 weeks plus norethistone acetate is very important because there is possibility of bone mineral density reduction because both can cause profound hypoestrogenism, GnRH plus letrozole. So we gave her for 8 weeks, then she came back. And again, we gave her, after 3 months, we gave her another 11.5 plus letrozole and norethistone. We were not satisfied with the volume reduction. Then we gave her another 3.75. And the volume now came down to 204 cc. In October 2020, she had a embryo transfer and she conceived singleton. You can see the early pregnancy. You see it's frightening because you see such a large adenomyoma, you know. It looks like something sitting inside a large adenomyoma. We were a bit worried. She had, you can see she had a beautiful triple line and single embryo, and she did very well. This is her scan at NT, 11 weeks plus 6 days. You can see again, the adenomyosis hasn't become larger. She did very well. We were worried about preterm labor or premature rupture of membrane. She went beautifully to 36 weeks. GDM, she was steroid covered and LSES was done. And now the baby is 2 years. She has done very well. Good volume reduction with a combination of GnRH plus aromatase, avoiding surgery, and there is no preterm labor. And you can get very good results with uterine volume reduction. But you have to be careful about loss of bone mineral density. So whenever you give a suppression with GnRH and aromatase, definitely give progesterone support. Even for GnRH analog alone, we give norethistone acetate 5 milligram per day. It is very important to prevent bone loss. So thank you all. And now I come to Dr. Parul. He can take up this case. This lady is 32 years, secondary infertility. First child is 7 years, menorrhagia, dysmenorrhea. And this is a finding that she has.
Please, the ICOG team has already said 0 time left for us.
Yeah.
Okay.
I think 7:15 we started. We have 10 minutes more.
No, they initially went to 0, then they gave us 45 seconds more. Even
Fine. So
let
us go ahead. Dr. Parul, what will you advise for this lady? Cystic lesion.
Sorry, I did not read your slide. What is it? 32 years.
Yes, secondary infertility, menorrhagia, dysmenorrhea, posterior wall, cystic lesion.
So let the panelists debate on that.
Yeah, Dr. Mala, Dr. Manjula, Dr.
Cystic adenoma, we need to definitely see that it goes. So it is juvenile cystic adenoma or whatever cystic adenoma. I definitely would think when menorrhagia and dysmenorrhea is there, that cystic part of it should be aspirated. So whether you're doing an endometrial ablation and removing it through the hysteroscopy or through laparoscopy, that has to be decreased.
But it will fill up very fast and
exercise
we went to laparoscopic drainage and fulgurated the lesion and gave her a GnRH suppression. And at the end of 6 months, she conceived promptly. And she had a cesarean section. This was 15 years back. So 15 years back, we did a laparoscopic drainage, fulguration, GnRH analog. Cystic lesions do not respond very well just to GnRH alone. They need some sort of drainage. Agreed with you, Dr. Manjula. So thank you all.
Thank you.
Thank you.
And this is one last case, 41-year-old lady. She had repeated miscarriages. She came to us at the age of 41 years, married to uncle, and she wanted egg donation because people had told her that you are married in the same blood. She wants egg donation, and she has this large posterior wall adenomyoma. So what shall we do, Dr. Mala?
Adenomyomectomy, ma'am. Large posterior wall myoma, adenomyomectomy. Then, of course.
Yes, and this lady did not want surgery. We went ahead with suppression and 2 embryo transfers. It failed. And then we went in for surgery. We did adenomyomectomy for her. Because when this advanced surgery, she was lost for follow-up. She came back after 1 year. So repeated embryo transfer failure. We did adenomyomectomy. Those days we had an open adenomyomectomy. I think this was way back in 2007. And post-operatively, we give her a GnRH analog for another 3 months. We did embryo transfer and she conceived twins this time. And she took the pregnancy beautifully to 34 weeks because we had waited for almost 6 to 8 months after surgery. And she did very well. And she had cesarean section and she had twin daughters in 2009. So the indication for surgery would be abnormal uterine bleeding or severe dysmenorrhea or recurrent abortion not responding to medication, IVF failures due to implantation failure. So only in these cases you have to do surgical adenomyomectomy. Otherwise, most cases less than 5 centimeters you can suppress very well with medical management. Because when you do surgery, there are very many surgery is not complete, symptoms will persist, recurrence rate is very high, spontaneous rupture of uterus has been described. So with all these reasons, today we prefer medical adenomyomectomy to surgical adenomyomectomy. But if there is, I'm not going through this, even the master Osada prefers to do an open adenomyomectomy for diffuse type of lesions. And he says for focal adenomyosis, you do a laparoscopy, the uterine integrity is preserved much better. Chance of rupture uterus are 6.8% with surgical adenomyomectomy compared to very, very less rates of rupture uterus after a previous cesarean or a myomectomy. So I think we have had, this is one very last case, 39-year-old infertility of 15 years, adenomyomectomy at a local hospital, recurrence in 1 year, 1 failed IVF elsewhere. She comes to us seeking pregnancy at 40 years. So what shall we do for her, Dr. Manjula now? Failed adenomyomectomy.
Yeah, but depends on who is doing it, how it was done, and how much was the.
Anyway, now she has come to you failed adenomyomectomy.
I think medical, definitely medical adenomyomectomy is what we should be looking at.
So we gave her 2 doses of long GnRH agonist, decreased in the size of the adenomyosis. She had ICSI with egg donation because she's already 40 years. 2 embryos, she conceived triplets, which became twins. There is always a dispute, should you transfer 1 or 2? We had transferred 2. It became triplets, 1 vanished to our luck. And she also had a low-lying placenta. She did very well. 36 weeks, she had a cesarean section, twins, 2.7 and 2.2 kg without diabetes. She did very well. This was March 2007. So I think we have had wonderful discussion. There is no further time. So let me conclude. Other cases we'll leave for the next time.
There is a question from one of the participants. You can look at the chat box and all the panelists, any one of you can respond to that, from Sindhura Bandi.
Yeah, so I think I have to stop sharing, then only you can see the. Yeah.
Please do that.
So though adenomyosis in the setting of fertility is challenging, you can do very well in most cases medical management. Do surgery sparingly only if there is a recurrent miscarriage or recurrent implantation failure in spite of medical management. This is the conclusion. And
so this is only for the fertility part. If it is for chronic pain, things may become different. So that
and then you can put in then you can give a GnRH analog followed by intrauterine device, and patients have done very well for 5 to 10 years. Again, we will not do an adenomyomectomy.
Okay. You are too biased, Dr. Asha.
We're not biased. We have a proof of so many cases.
Because GnRH analog also, we would be quite reluctant to give just for the pain relief for a short period of time. It has to be
followed by intrauterine device, and patients have done well for 7 to 10 years. Actually, the dictum says you can keep the Mirena for 7 years, not just 5 years.
I know, but Mirena doesn't work in all cases. Very few cases.
So this discussion we'll have next time.
Can I just add one thing, Dr. Parul?
Yeah, one question I would ask all of you. If you are putting Mirena, the uterus size is large, will it be remaining there or will it be thrown out?
So that's why they say, that's what I wanted to say.
Up to 12 to 14 week size uterus, you can give a long GnRH.
So
and after 12 weeks, you put a Mirena.
So we have now a very clear.
But if it is bigger than that, you should.
Please listen to me. 150 ml size of uterus on ultrasound. That would be appropriate. Anything more, Mirena is not appropriate for.
Absolutely right, doctor. I agree with you.
Yeah.
So that's
why
why
I think we will have one more session of discussion on pain management. And what are the questions here? Dr. Parul, you want to take up anything?
So I thought it is a longish question. So any one of the panelists can read it up and respond.
I have answered there. It is the LNG-IUS is the best thing for that girl.
Okay. Okay. So that's about it.
Yeah, great for endometriosis, dysmenorrhea. Yes. LNG-IUS is good.
Uday hasn't come back, so we can go back to Dr. Lakshmi for her comments.
So thank you all for your wonderful participation. It became very interesting with all your contribution. Thank you all so much. And thank you, Dr. Parul, for giving me a free hand. Thank you so much for that. Very grateful to that.
Very energetic presentation. I compliment you for that.
Now let's have post-test. Yeah. So Komal, you can post the post-test link in the chat box, and dear delegates, you are having 10 minutes to solve those MCQs.
I can see Dr. Uday Tanawala, if he has some expert comments to be made, we can have his
I had an emergency, so I just had to leave in between. But it's an extremely interesting discussion. It was great listening to Ramani Devi with her lecture. Many new things even I learned. And of course, the case discussion, I was there in the beginning. It was the medical management and all was excellent. And I'm sorry, but I had to just leave in between for an emergency, and I will have to just go back again. But this is great going. So let us see how everybody does in the post test. And I'll leave it to Parul and and Asha to take it up.
Thank you, Dr. Navala, so much. I know you were very busy. In spite of that, you agreed to grace the occasion. Thank you so much for the kind words.
Thank you, and great to see you, Lakshmi. You are doing a great job.
Thank you. Thank you.
And I thank Dr. Lakshmi for having given us the wonderful opportunity here today for the panel discussion.
So she has already posted the link and timer start kar do, Kamal. So it is time for post test. Yeah.
Yes, Neha?
So time is up. Komal, you can deactivate the link. Sneha, you are taking answer key. Sneha, you can unmute.
Yes,
Ramani is taking.
Yeah, I think Ramani madam will conclude.
Yeah.
No, Asha, today Asha madam's day.
Asha?
I have called her already. She's there.
Oh, thank you. So I think we have had a wonderful day today. It was a vibrant scientific
They
session.
have to post the right answers, madam.
Yeah, you have to take that answer key for them.
Yeah.
One of you has to take the answer key.
Post questionnaire. Tech support, please post.
Should I share it, ma'am?
Yes,
Yeah,
yes.
please.
Yes.
Ramni?
Ma'am, is it visible?
Yeah, it's visible. Ramni, you can just tell the correct answers to all the questions. Yeah.
Asha madam?
Can you see, Asha? I think
Yes, I can see. The correct answer is stage 3.
Stage 3.
That is 3.
I think you can
Number
read
3.
You can read the answers.
Yeah. Second question, Komal. आगे जाओ.
Second answer is answer for rectosigmoid. That is number 1.
NCR classification.
Again, number 1, that is DIE. Idea group. Who gave the systematic approach to sonographic? Idea group is number 2.
Narendra had given an extensive talk about this.
Next.
Very nice talk.
Next.
Next question. The following biomarkers indicate development of DI, that is urocortin.
Urocortin.
Next, Komal. Whose theory best describes association between Mullerian anomalies and endometriosis, that is Sampson's theory. Next, functioning rudimentary hormone with endometriosis manifest as. So, secondary dysmenorrhea, abdominal pain, and inguinal hernia.
All of the above.
All of the above, yes. The prevalence of endometriosis is non-obstructive Mullerian anomalies is higher in unicornuate uterus. Number 3. Next. The gene associated with Mullerian anomalies and also its altered expression results in decreased implantation in endometriosis, that is HOX gene mutation. Next. Incidence of endometriosis in Mullerian anomalies varies between 30 to 40%. Second. Next. Recent guidelines to perform surgery with ovarian endometrioma prior to ART can be considered to improve pain and accessibility of follicles. EFI includes all except AMH. That's the answer.
Developed by Adamson and Pasta. EFI. Infertile woman with endometrioma size of 3 centimeter. Following is recommended by ESHRE to improve pregnancy outcome. Answer is ART directly if follicles are accessible. 3 centimeter. No need for surgery. This is Narendra has shown a nice picture. Indian headdress sign. Percentage of women with endometriosis having DIE, 15 to 30%. What is the incidence of ureteral endometriosis? 1%. Which is the most common site affected in ureteral endometriosis? Left distal. Which is the first line investigation if there is suspicion of ureteral endometriosis? Ultrasound. A 42-year-old female. The answer here is ureteral resection and end-to-end anastomosis. Which is the approach chosen for ureterolysis during TLH? Medial. What is the rate of recurrence of cyclic pain associated with endometriosis after hysterectomy with preservation of normal ovaries? 3 to 7%. The answer here is medial pararectal space dissection. DIE, 5 millimeter and more. Symptoms of ureteric endometriosis, loin pain, renal failure, hematuria, all of the above is the answer. Ideal classification of Mullerian anomalies, Eschre ESG classification. Pain associated with endometriosis has been attributed to all of the above. That's focal bleeding from endometriotic implants, action of inflammatory cytokines in peritoneal cavity, infiltration of nerves in the pelvic floor. All of the above is the answer. Components of, this is always I think of Ramani, HWW syndrome, absence of ipsilateral kidney, uterus didelphys, obstructed hemivagina, all of the above is the answer. EFI includes historical score, surgical score, least functional score at the end of surgery. Answer is all of the above. EFI score is validated score which accesses the chance of spontaneous conception after 2 to 3 years. This is the only boring point, Ramani, that we have to wait for 2 to 3 years.
Yes.
Yeah. So this was all about post-test.
Yeah.
So Ramani?
Hello.
Yeah.
One thing I
Parul,
wanted
your
to know.
comments, please. Yes. Yes.
No, the incidence of DIE in endometriosis 30 to 40% is a bit too big. I don't think that is true. If there is some reference, it has to be kept there. But my impression is 10% DIE of all endometriosis. What do you say, Dr. Ramani or Asha?
Depends on what stage you see them in. Most of the patients that we see are mostly in about stage 3.
No, all endometriosis overall, how many of them are DIE?
I would say 30%.
30% DIE, I think that is too big a number because surface endometriosis is almost 60% to 70%. The cysts are again 15 to 20%. So DIE is much less. But anyway.
Because we do not, how do you conclude? How do you exclude? That's why we think it is less.
No, I am just talking about published data, not my own perception. Okay. But if there is such a reference, it is fine. I'll accept.
Even for adenomyosis, I have seen a reference which says in case of endometriosis, 70% can have adenomyosis, which you do not agree at the first instance. But this is the third.
That is
70% can have adenomyosis. So it depends on how deeply you investigate. What are the modalities you use to investigate?
Okay.
Somebody has asked whether it is septate uterus or uniconvate uterus, which has got the higher association of endometriosis.
No, septate has a higher, but it was the reverse. Here it was mentioned that lesser incidence of endometriosis. So unicornate is lesser because it is single cavity, less amount of retrograde.
And there is no peritoneal spill is not, there is no obstruction.
Much lesser spillage. Yes.
Yes. Madam, this I had a...
but again, if it is septate without obstruction, you do not have, I have not seen many cases of endometriosis.
No, madam.
No, very high incidence.
There is no obstruction, the incidence is higher than the general population.
I would say almost 40 to 50%. But if you do not put a laparoscope, then you may miss it. The surface endometriosis is quite common with septum.
Uniconvate, I have not seen.
Yeah,
but,
it is less.
I think madam has taken reference from somewhere. It was...
in fact, I would say uniconvate, I have seen many.
Okay.
But I would suggest that when
I think I'm going to take my own data and I can come back after about...
But Lakshmi, we can... during the answers, we can also mention the reference. Okay.
Yes.
That would be
Yeah,
better.
we can do it next time. Yes.
In future, not for this.
Yes, yes.
So if there are no more questions, Ramani, I think we can wind up the course. And dear all, we look forward to see you all tomorrow at sharp 4. So Komal, you can stop the recording. Yeah.
Yes, ma'am. Yes, ma'am.
Thank you. Admire your energy, Dr. Lakshmi and Dr. Ramani.